Hello, everybody. Thank you for coming. I can invite you to come a bit closer. This is an interactive session. We can interact if you'd like.
Okay. You don't want me to come out to the audience, so I invite you up here. There we go. All right.
Bonjour tout le monde. Donc, je m'appelle Sarah Girard, je suis pharmacienne au CIUS du Nord de l'île de Montréal. Je suis co-responsable des sessions de pharmacothérapie. Alors, on vous souhaite la bienvenue et on va parler d'occlusion intestinale maligne aujourd'hui.
Hi, welcome everyone. So I'm Dr. Dajne, pharmacist also at the CIUS Centre-Ouest de l'île de Montréal and scientific planning committee member. So I'm very pleased to introduce our speakers for this afternoon. So we have Dr. Janet Abraham, which is a national leader in the field of palliative care and a professor at Harvard Medical School. She received her MD at the University of California at San Francisco, completed her internship and residency at the Mass Gen Hospital, and served as the chief resident at the Moffitt Hospital of UCSF. After completing her fellowship in Hemonc at the Hospital of University of Pennsylvania, she stayed on to work for 20 years. In 2001, Dr. Abraham joined Dana-Farber Cancer Institute as a full-time palliative care physician, founding the Adult Palliative Care Service there and at the Brigham and Women's Hospital. And then we have Andrea Enzinger, Dr. Andrea Enzinger, who received her medical degree from University of North Carolina and completed her residency in internal medicine in Beth Israel Deaconess Medical Center and completed her fellowship in training in both palliative care and med-onc at Dana-Farber Partners Cancer Care. She practices both medical oncology and palliative care within the Dana-Farber Gastrointestinal Cancer Care Center. And finally, we have Dr. Colleen Feltmate, which is an assistant professor in obstetrics, gynae, and reproductive biology at Harvard Medical School. Her research interests includes ovarian cancer, cervical dysplasia, and gestational trophoblastic tumors. So as you see, we're in for a treat, and I'm very pleased to have lined up this incredible amount of people here. So please join me welcoming them.
Well, good afternoon. I think this might be too loud. All right. We're so pleased to be here, and we're pleased to see such a large room of attendees. As you've already heard, my name's Andrea Enzinger. This is Colleen Feltmate and Janet Abrahm. And we've had a lot of fun putting this talk together and working together because we come from different backgrounds, me being primarily a medical oncologist, but also palliative care trained. Colleen being a very active GYN oncologic surgeon, and Janet practicing in palliative medicine. And so we wanted to be able to kind of bring our lens and our different perspectives to a really complex, multidisciplinary, challenging problem we all deal with. We thought it would be helpful to get a sense of our audience and also to really invite you to pipe up, to raise your hand, to ask questions, to come to the microphones up here. So we're going to be talking to each other, and we want for you to please be part of it. So could I just get a show of hands first? How many of you are a nurse or practicing in the field of nursing?
Oh, great.
Okay, good.
Lots of nurses.
Super. How many of you are physicians? Okay, so a lot of physicians. Advanced practice providers, so nurse practitioners, PAs. Okay, pharmacists, great. Social workers,
Chaplain.
hospice,
Chaplain.
chaplains.
Yeah.
Okay, terrific. And I think a lot of what we're going to touch upon today really spans these different disciplines, and so we'd love to hear from you and your kind of experience. So, these are our disclosures. There's nothing terribly relevant. Our learning objectives today are to recognize the clinical presentations of malignant bowel obstruction, to incorporate understanding of the pathophysiology of malignant bowel obstruction and disease status into treatment options. It includes choosing medical therapies rationally for goals of resolution and palliation of symptoms, deciding when and if surgical intervention is reasonable, and discussing the importance of goals of care during this episode. And our presentation includes aspects of the following CAN-MEDS competencies: medical expert, communicator, collaborator, scholar, professional, patient safety, and QI. So I'll pass this along to Colleen to talk about a case.
Okay, so get this in the right place. So I thought it would be helpful, and I always find cases to be really enlightening because we all deal with aspects of patient care, and hopefully with each of these cases you can find something that you can relate to or that triggers questions, and we really encourage you to get up and ask those questions. If you want to raise your hand and come up, please do. So I'm going to start with case of mine. Now, the picture is not a real picture of my patient. I'm just going to say that right off the bat. But this is a 56-year-old female who had a history of stage 3 ovarian cancer. She underwent surgery and chemotherapy 2 years prior. She completed all this and has been doing well since. She then presented with worsening nausea and vomiting over a couple weeks' time. She presented to the emergency room as she started to note her abdomen getting bigger, and she started feeling more bloating. Her tumor marker was somewhat elevated, with the CA-125 being about 10,000. Her CEA was less than 5. And at this point, we started to think about imaging. Now, I bring this case up because I think it's important to understand that there are 2 pathways for bowel obstruction. And while we're talking about malignant bowel obstruction, in this particular case, you might also think about the pathophysiology of just obstruction in general. So this is someone who had surgery, and if you didn't have that marker, perhaps you might think, well, maybe it's because she has some type of adhesion. So we're going to talk about the fact that bowel obstructions have a series of different presentations, and we think about symptoms being things like nausea and vomiting, constipation or obstipation, colicky pain, abdominal pain, bloating and fullness, early satiety. But there's a difference between how someone presents when they have what's called a malignant bowel obstruction versus something related to prior surgery or adhesions. And I've made a list just so that you can understand. Sometimes these present very differently. When we see someone who has an acute onset of pain, they have nausea and vomiting, we think, oh, maybe this is just an adhesion. When somebody has a slow, ongoing presentation of not doing well, not feeling well, bloating is increasing, intermittent nausea and vomiting, we might think this seems more consistent with a malignant bowel obstruction. The first thing we think about when we're trying to rule this out is getting films. And the easiest film to think about is actually an old-fashioned upright, a KUB, flat plate, where you take a picture and you look to see what the bowels are doing. Here is a classic appearance of what we call a fluid level. So the drain has stopped, everything has backed up, and you see gas, a straight line where the fluid is. And this seems to indicate that there is clearly something preventing something from going through. So you get this gradation of gas and then fluid.
And Colleen, I wanted to mention that until you got that x-ray, when the person presented in the emergency room, if this was very gradual, sometimes the clinicians who are admitting a patient like this is wondering, well, how could she or he let it go so far? Like, wouldn't they notice that their belly was swelling and that then they might not have come in, though, until they had nausea and vomiting. And so we might take the wrong picture of a person thinking they're in denial or thinking that they just don't want to deal with the medical system. But from what you explained, it can be normally very insidious.
It can be, and I think it's also difficult when somebody's been treated for a cancer to think to themselves, oh God, is this coming back?
Yeah.
And do I really want to know that whether or not this has come back? I think I'm just going to hold off. Maybe it's just I haven't been eating well lately, and maybe I have celiac.
Yeah.
You know, there can be a certain amount of denial in that.
Yeah.
So after we think about a plain film, oftentimes we need to know more information. So the next step is normally a CAT scan. And I would say there aren't as many what we call plain films anymore done. It was something that was done many years ago, but in some places, if they go to an acute care facility and there's not a CAT scan available, the first thing might just be a simple x-ray. And you can make a diagnosis or a suspicion of one from that. So now we see the CT scan, and there's a little bit more concern. We see places where there seems to be fluid, and then there's gas, and then there's sort of no follow-through of this fluid. So now we're definitely concerned that there might be a blockage. And at this point, the question is, what really is going to be, what's the next step? Ooh, I went the backwards way. So in understanding the pathophysiology of bowel obstruction, we think about two pathway mechanisms. One, where there's this focal mechanism, either from an extrinsic compression, like a large mass, and this is sometimes how someone can present. And then following this are things like tethering from adhesions, or when you see a picture of more diffuse, not real obstruction, but kind of spotty looking fluid going through the bowels, we might think of something called carcinomatosis or lead pipe syndrome. And the CT might not even look like there's really an obstruction, but all their symptoms point to that. And these are just a few pictures to show you, if you're not a surgeon, what we can sometimes run into as surgeons for these various scenarios. Either way, it's resulting in delayed transit and kind of distension of the intestine.
Yeah, and I would just echo kind of what Colleen's saying about the subtlety. Sometimes when you have this diffuse carcinomatosis and kind of just cement kind of caking the bowel and then nothing's moving through, because we'll see these patients in clinic and they'll maybe not be tolerating their chemotherapy well, they're having a lot of nausea, vomiting, but you're getting imaging, nothing seems like it's growing, you don't really see clear masses. But they're losing weight. And often what we know is that imaging far underestimates the extent and particularly the impact of disease when we have this diffuse pattern. Thinking about the other scenario, so a more focal bowel obstruction, which I see frequently as a GI medical oncologist, we think about kind of where is it happening in the GI tract. So I see a lot of proximal obstructions, either at the gastric outlet or just in the kind of the duodenum or early small bowel. These patients present with a lot of fullness or discomfort or early satiety, and then projectile vomiting often. We most often see this with stomach cancer, but also pancreatic cancer. And this is important because we'll get to later, management is often different. But we can see this as well with distal obstructions, so colonic obstructions. I often see it with colorectal cancer, but Colleen was telling me that you can often see this with ovarian cancer as well. And sometimes you may have multifocal, so not necessarily the diffuse kind of lead pipe type picture, but you may have an obstruction earlier in the GI tract, and then also a second obstruction that's lower down in the colon.
Yeah, so I wanted to add one of the interesting points that I think I taught Andrea was we will do a CT scan and we'll see a point of transition where there's an obstruction in ovarian cancer. And I said, well, before I take anyone to the operating room to get rid of that point of obstruction, the next thing I do is a barium enema or gastrograph and enema to make sure they don't have a secondary obstruction where it's beyond what that contrast got to. So,
yeah, and that's something I've seen less of with our surgeons, so I may start reminding them. We'll see what they think about it. So just to get to kind of the pathophysiology and what we're dealing with, because that's really important when we shift gears to talk about drugs and the tools that we have in our toolbox to palliate the symptoms. So when we have a bowel obstruction, the bowel continues making its normal secretions, right? We continue having secretion of just digestive enzymes and fluid, but when nothing's moving through, you end up having upstream dilation. The bowel gets more and more dilated, and as that happens, it actually causes damage or pressure, even ischemia to the bowel that's above hand. And that leads to then kind of release of prostaglandins, vasoactive intestinal peptide, and other vasoactive substances that then kind of stimulates the epithelium to make more fluid and have more inflammation. We get more distension. We get uncoordinated peristalsis, pain, and so on. And really what we want to do is try to stop these various actions with the treatments that we have available to us.
So this slide is really meant to talk much to Andrea's point about what goes into gut distension. And we think about certainly the mechanical obstruction, and then there's the potential for invasion of sort of nerve fibers causing that lead pipe syndrome, or inflammation or an ileus type of picture. So all of these lead into gut distension. But then we get into the cycles of what continues this going through, and we talk about the fact that as the epithelium distends, you get increased secretions. The more secretions you get, the more gut distension you have. And then we get into ischemia and damage and inflammation and more secretions, and back again it goes. And lastly, we get into just as you get more and more stretch, you just get relative atony, and the bowel just becomes discoordinated. And each of these colors represents a potential for where we can talk about medication or intervention as a next step.
I seem to have a different chair than everybody else. And I felt like I was sinking into it, so I hope you don't mind if I sit up here to talk to you about drugs. Drugs, my favorite thing to talk about, yeah. Oh, I forgot. In my disclosures, I didn't put that I went to Berkeley. But besides that, we could move on.
We're gonna change your chair.
Oh.
We're not gonna let you stand like
Okay, I'll stand for a second then.
this one better.
Let me see if this is a little higher. Yes.
You're not sinking down.
As we said, this is a very informal talk. Anybody who needs to move, please feel free. So medical therapy of malignant bowel obstruction. Let's see if this is working. As you can see on the left column, there's a bunch of drugs that I'm sure you all use. Corticosteroids, metoclopramide, anticholinergics, opioids, PPIs, octreotide. Each of these has its own benefits or harms. And again, across the top are benefits and harms: decreased gut secretions, improved gut motility or decreased gut motility, and decreased inflammatory mediators, as well as symptom relief. So most of the drugs we use in palliative care of these patients, and in this patient, we would be using these drugs while we were waiting to see if she could get surgery or active antineoplastic therapy. We would want to give things for symptom relief. We are lucky enough to have clinical pharmacy partners on our inpatient and outpatient teams. And so one of the things we would always do is we're trying to figure out which of these drugs might benefit or hurt our patient, would be to check in with our pharmacist, who would usually have up on their computer all the other medications the patient's receiving. So that's clearly one of the most important team members for us in our oncology and palliative care teams, but especially our palliative care teams. So why would I use corticosteroids? Well, we know that they help pain, but they also, interestingly enough, decrease gut secretions and, of course, decrease inflammation. So if we're going to try to break the cycle, we might want to start with corticosteroids. You all know the many contraindications to corticosteroids. For us, it's often an elderly patient, somebody who we might push into delirium, somebody, of course, with uncontrolled diabetes, somebody who gets kind of manic. We usually ask them if they're a cancer patient and have had chemo before, how they did with the Decatron that they got with their chemo. Were they up all night cleaning the house? Were they profoundly depressed? You know, what happened to them? So we always try to find out for all of these drugs what their previous experience was with the drug when we decide which of this cocktail we're going to put into action. Of course, you can't use metoclopramide if they have a complete bowel obstruction, but it does help improve gut motility so that you can try it. And if they have more pain, then stop it. But if you think it might be partial, some of these other things decrease gut motility. So it's very useful to try 5 Q6, something like that, IV, to try to improve gut motility. Have you had your patients with partial bowel obstructions use metoclopramide?
Yeah, absolutely. We do it outpatient all the time when we have these sort of stuttering, kind of evolving bowel obstructions, and often can kind of keep people from, you know, becoming fully obstructed. And I think that the cramping is the real challenge.
Yeah.
Do you find that it's less cramping when you start with 5 milligrams, Jan?
Yeah, I find it's less cramping, and I also do it standing, because nobody's going to ask you for this. I mean, the patients need a regimen. It's one thing to have PRN pain medicine, but they're not going to ask for metoclopramide PRN. And they're not going to be eating, so you can't do it before meals. So it's important to give it 3 or 4 times a day, depending on what you think. And it really doesn't prolong the QTC that much. And in the short run, it doesn't give you extrapyramidal symptoms. I mean, that's very unusual. But clearly, if somebody had a bad experience with it before and got akathisia, you definitely want to find out about that, because akathisia is very unpleasant.
Do you mind me asking, Janet, how do you approach kind of the duration of the steroid therapy? You always sort of think about asking oncologists, is it okay to use or not to use? And but really, what period of time are you thinking about using this?
I think for inpatients, it's until the bowel obstruction resolves, and then certainly tapering it, and depending on, if you think they're going to surgery right away, then I certainly wouldn't use it. And I don't know if that's a contraindication, Colleen. Is that
No,
a problem? It's not a problem.
I don't usually think so. And you know, I was thinking about corticosteroids. I remember 20 years or so ago, we didn't always start with that as
Right.
something, and I find that that's incredibly helpful. That actually is one of the key aspects of this that I've learned through working with you as a surgeon, and I don't worry about steroids in the setting of surgery. I mean, you know, these are quick pulsed. You're not on it
Exactly.
chronically. It's not going to make a difference for their healing process in this setting. I mean, the worst aspect of the healing process is somebody who's come in who hasn't been eating for weeks.
Yes.
That
Yeah, that's
worries
worse.
me more than the acute use of corticosteroids.
Okay, well, that's really helpful, because we find them incredibly helpful, especially with the decreasing of the secretions. If you can do that, plus pain relief without opioids or with minimizing opioids, that's really going to be a huge benefit to the patient. And you might start with 4 twice a day. There's no data. Unfortunately, there's no randomized controlled trials of what I'm telling you. There are prospective trials. The Grenoble study was the oldest, and I'll tell you about some other more recent ones, where they use these drugs in combination. And steroids were a very important part of people like this patient who it's their first bowel obstruction. The ones who had not used steroids before and who got steroids, they're the ones who resolved. So it's a very important part of this regimen. We tend not to use anticholinergics that much because they decrease gut motility and you get less bang for the buck with them than you do with the corticosteroids. We do use opioids for pain relief, and they do decrease gut motility. What drug to use? Well, again, with opioids, you always ask the patient, have you tried any of these things before? Because you don't want to use one that they have a bad experience with. Use something intravenous, but if they've had a bad experience with morphine, even if it had nothing to do with what's going on now, that's the last thing you want to do is add an opioid that they had a bad experience with so that they get more anxiety. Most of them haven't had hydromorphone before, or they've had a good experience with that. Oh, sorry. I'm sorry. I didn't see you over there because you're right behind. Thank you for pointing that out. She is right behind a piece of equipment. Yes, please.
I'm going to interrupt you now because I'm going to forget by the end of this conversation.
Sure.
But with the steroids,
Yes.
I've heard two ways of going about it. So once you commit to using steroids, I've heard go slow and increase, or start at a very high dose, and then once you get results, decrease quickly. What's your favorite way to go?
Excellent question. For me, partly it depends on how large the bowel is. So if I have a hugely distended bowel, I'm a little worried about using a high dose of steroids in terms of perforation. Where I start high and go low more often is with pain relief, actually, with neuropathic pain relief, because I want to be sure that it actually does something for neuropathic pain. With bowel obstruction, I don't usually do that. I usually just use maybe 4 milligrams twice a day if that's a high dose. At 8 and 2, remember, don't give it BID or your patient will be awake all night. It'll be scheduled 9 and 9 unless you specify. This is the palliative care part of me. Unless you specify 8 and 2, they're going to give it BID, 9 and 9. So I would use 4 BID, and then maybe a lower dose is 4 a day once you get control, and then taper down from there. But I wouldn't use 10 milligrams, for example. Do other people have other experiences? That's pretty much, there's no data on this, so it's hard to say, but that's pretty much the dose that seems to work, is the lower doses of 4 milligrams twice a day. And again, just as she came up, thank you so much for doing that. Definitely interrupt us. It's very difficult to see with the lights on us, so we may not see you until you get to the microphone, or our friends, or help. Opioids, again, as I was saying, are very important, and it's very important to use one that is helpful to the patient and that they are not afraid of. If you have a blood pressure problem in the patient, you can use fentanyl because that doesn't affect the blood pressure. That's the only kind of consideration I have there, but it will slow the gut. We like PPIs because they decrease gut secretions as well. So they're very important for that. And octreotide we give later. Octreotide, as you know, decreases secretions mostly from the upper part of the gut, somatomedin inhibitors, so that if you're getting a lot of NG tube fluid, that's, Mercadante first reported this actually in ovarian cancer patients many years ago, in the 90s, I think, in Palermo. He was the first one to show that you could avoid surgery, inventing gastrostomies, all the things we'll tell you about, with enough octreotide. However, it really decreases gut motility. So in the protocols we'll show you, we delay the use of octreotide usually. Any questions about this kind of, or other things that you take into consideration when you choose which of these things that you're going to include? I may have forgotten something. Do I see somebody coming up? Yes, good. Okay.
Hi there, yes, thank you. My question is about octreotide and the NG. My teaching has always been that if you're having tons of NG output, you're going to keep the NG. The role of octreotide is limited in that context. So are you using both NGs and octreotide, or are you using octreotide to try and wean the NG, or the other way around?
Again, an excellent question. Yeah. So we use octreotide and NGs, but we would use the NG probably first in a patient who is not drinking at all. I wish we had more of those patients who, once they have an NG tube in, a lot of our patients will drink even though we ask them to be NPO. Mm-hmm. So if somebody is not going to get weaned off drinking, there's no reason to use octreotide. All octreotide is going to do is decrease your endogenous gut secretions, which are about 1.5 liters a day for your stomach, and a little more, another 1.5 liters or so for your small bowel. But the stomach especially, you can really decrease stomach secretions. But I've had patients who really did not drink at all and did not want any other procedures and didn't want an NG tube. And
Yeah, I was just going to say, yeah, just to add, I think we're pretty, once we, in a setting of a bowel obstruction where we're trying to sort out where we're going to go, I'm very strict about the NG and about drinking because we're at a point where we're trying to figure out what route are we taking. We need to understand where they're at and what are the interventions that we're doing for that individual. So the nurses are pretty strict about ice chips and, you know, it's
good. Not on the medical services.
Yeah, on the surgical services are probably better, but that's a really good question.
It's a really good point. And so, yes, if they're not having much NG, if you can get that NG output down, as we'll explain a little later, it's definitely worth doing them together.
And as a follow-up question, do you go full tilt to the octreotide, like 150 mics TID, or do you start low, go slow?
So could you wait just for a little while?
I could.
And
yes, no problem. Thank you.
Andrea will be happy to answer that question for you.
We paid her for that.
And
Yeah, that was really good.
just to answer a little bit about that same
course.
question, even the studies looking at either octreotide or we'll talk about data with lanreotide, which is sort of a new generation somatostatin analog, the trials accepted people that had NG tubes, those that didn't have NG tubes, and so they've been tested in both kinds of populations. So you're looking to see, is it going to reduce either the volume of emesis or is it going to reduce the volume coming out of the NG tube? So I really think it's useful in both settings when you're trying to minimize that.
But remember, as a caveat, work with your nurses, and many nurses are here. If you can encourage the patient not to drink, if there's another way you can work with them, that's going to be the real test. If they really don't want another intervention, we might be able to do it with just the octreotide. And you might be the key to that. And you certainly, please share with the medical team when they come by, because certainly when Colleen's team comes by, that patient is not going to have any of the water or anything that they've been drinking at their bedside, because they know that she's not going to like that. But you'll be able to help us and really motivate the patient not to drink if they have a bowel obstruction. Some other questions?
I have two quick questions, but sort of related with the idea of the gut dysmotility. And I've often wondered, just with so many of our patients being on high doses of opioids, how much in the absence of these really like single transition point, very obvious mechanical obstructions, that gut dysmotility is driving a lot of the obstruction. And so I also have always been taught that metoclopramide is contraindicated in complete obstruction, presumably because of a risk of perforation. But I was curious what the evidence was behind that. Like if we actually in clinical practice see a lot of obstruction, and whether it would be worth trying even in the setting of a complete obstruction if they're on high dose opioids and we're really thinking that dysmotility is driving this. And then in the similar kind of question, whether you're ever considering using something like methyl naltrexone, like opioid antagonists in the setting of these bowel obstructions. Because again, I sometimes feel that I've seen people who are so slow in terms of their gut dysmotility, perhaps related to opioids, that it's really driving a lot of the obstruction.
Well, I would say that in many cases, we're not 100% sure it's a complete obstruction, and we do try metoclopramide, and the patient has terrible cramping, awful pain, and that's so that if you're, obviously if they're putting 2 liters out through their NG tube and they're not drinking, it's more likely it's a complete obstruction. But if you're not sure, we definitely do try it. And I don't know if anybody who was brave enough to give somebody metoclopramide, to be honest, in the face of a complete obstruction. Do you know any data on that?
I don't. I mean, I think that it's a great point, and I more find myself wondering in the grayer zone where you're not sure, is this a partial obstruction?
Yeah.
Is this just severe constipation superimposed with dysmotility? And I completely agree, and I would advocate for using metoclopramide in that setting. What you were starting to say made me think about a conversation we were having amongst ourselves about the role of opioids, and Janet is warning us about decreasing gut motility. And I know I think back to times I was training with sort of old school oncologists that trained back in the golden days of the NIH, and they say, well, don't give opioids because you're just going to make it worse and you're going to slow everything down. And I'm unaware if there's really data that happens. I mean, I've always thought of opioids as having more of a direct impact on colonic motility. And so, having a major influence, of course, on constipation. But I'm, clinically, I have lots of patients that I manage who don't have bowel obstructions, may not have GI kind of carcinomatosis, and they have severe constipation. I've never seen them develop a de novo bowel obstruction just from taking opioids. So I don't know, Janet, if you have any perspectives about kind of how much we need to worry about titrating opioids. Should we really be minimizing the dose to try to help the bowel obstruction improve?
I think those are really good questions, and I think that a bowel obstruction is a profound event in somebody's life. It's scary. It raises all the issues we're going to be talking about. Does somebody need surgery? Do they need a procedure? This is their first recurrence. Does that mean they're dying? I mean, all of those things. So all of you who are here as palliative care physicians know that the anxiety, the spiritual questions, the existential questions, all of those need to be addressed as we think about the pain someone has experienced from a bowel obstruction. And sometimes we can forget that, or if we're not consulted, people don't have the skill set necessarily to address spiritual concerns or existential concerns. And so while the nurses in the audience may be doing that automatically, and the social workers, I'm not sure all the, in the palliative care audience, we would be, but by the time we're called, I guess what I'm saying, all of those things are exacerbating the patient's experience of pain and suffering. So one of the main things to do to minimize opioids is to be a good palliative care clinician and address all of those issues, and especially address the anxiety. And then there are other medications that can be used to help the patient's pain and anxiety that don't slow the bowel. And often that's what one of our most important interventions is actually lowering opioids, doing counseling, replacing things that slow the gut with helping the person who is suffering. My concern with methyl naltrexone is that if you're not sure if it's constipation and there aren't air fluid levels, and they have been on opioids as an outpatient, be sure that you empty the lower bowel first. So do lots of enemas, make sure that that's clean, and make, again, very sure there's not a transition point, because methyl naltrexone will perforate bowels. There's good data on that you'll get bowel perforations if you haven't cleaned the bowel out below where the methyl naltrexone is working, which is in the opioid receptor rich, area of the gut. So if you're not sure about a transition point and the patient won't let you, or whatever reason you can't clean out that lower bowel, I would be very cautious about using methyl naltrexone in those patients. I don't know if that's your experience, but hope that answers your question. Sure. One more.
I'm sensitive to your time. Would you prefer to continue and take more questions later, or do you have time for one more?
If it's about this area?
Absolutely,
okay?
it's about this area.
We've planned, we hope, 45 minutes worth of interaction and 45 minutes worth of presentation. So
amazing.
We hope that that's how it's going to work.
Yeah.
Thank you so much.
Sure.
So I was trained also in the way back years, where we very much looked at bowel obstruction two ways, which was bowel obstruction you were going to try to open up, and bowel obstruction you weren't. And so I still have that kind of in my head, and said, I'm wondering, are we now in a bit more of a stepwise approach to bowel obstruction, saying add on one agent, see if it opens them up, add on a second agent, or are we adding on all the agents simultaneously now and saying let's go to open people up first, steroids, PPI, metoclopramide, maybe H2 blockers if that's something else that you guys are using. Maybe you can comment on that. But and that agents like octreotide and opioids and things like that were the main focus when we were trying not to open people up, and that we're focusing more on their quality of life, but no longer trying. Like I was very much sort of taught that octreotide was very much for the category where we were not expecting people to be opened up anymore, and maybe that's old school.
I think that part of it is old school because. Well, it depends what you mean by opened up. If you mean preventing an NG tube, I mean, I mean,
allowing
it's more symptomatic, you're right. They're not opening up, or they're opening up a little but not enough, and they would need an NG tube otherwise. But I think more importantly, actually, we can answer your question more fully in the next few slides.
Beautiful.
If that's okay. Yeah.
Then that was just a segue.
Oh, thank you. I appreciate that. We have a question over here.
Okay. I am a palliative care physician at the CHIM Tertiary Center here in Montreal, and we encounter a lot of patients who are going to have or are on immunotherapy, which puts us sometimes at a limiting place with our corticosteroids. We were wondering how you approach that in your centers.
Andrea? I mean, I can say we have been told by our oncologists that if you need to use the steroids, use the steroids.
Yeah.
That's what they always say. And again, this is going to be a short trial. It's going to be like a week.
If
You'll see, we're going to know in a week if we need the steroids, and then we can always taper them off. But just like when they have a severe immune reaction, they say use the steroids if you need the steroids. Is that fair, Andrea?
Yeah, if you're going to have a response to a PD-1 inhibitor or other checkpoint inhibitor, steroids aren't going to blunt it. And if you're not having a response, adding steroids won't hurt it. So.
And the thing is, if you get an obstruction, you're stopping everything. So I think that's really important to understand. As soon as the obstruction happens, all chemo, all immunos is off. So now you have to deal with the next problem.
This is great. This is exactly what we were hoping for. So thank you all. Let's see. So I wanted to highlight the Princess Margaret program, which has been going on, or at least was published in 2016, and I wasn't able to find too much more recent stuff, but except for 2019. But at Princess Margaret, they have a unique, I think, comprehensive interdisciplinary program for ovarian cancer patients at risk for malignant bowel obstruction. They have integrated their outpatient and inpatient care by specialized oncology nurses through telephone conversations in the outpatient setting. They have an interprofessional team that reviews each patient and creates treatment consensus and supportive care plans. They've standardized their clinical processes, including imaging and symptom management medications, their assessment tools, which is a really elegant screening tool that the nurses are using in the outpatient setting, and electronic health record documentation. They have early goals of care discussions. They have extensive patient education materials for those whose malignant bowel obstruction resolves. And they have a lot of data. This was published in a retrospective analysis in 2019. So they compared the people who had malignant bowel obstruction before they put this protocol in place and after. As I said, there are no randomized clinical trials yet, and that'd be pretty hard to do. So they had a shorter hospital stay, 13 versus 22 days. They had overall survival that was improved significantly, 243 days versus 99. More patients received palliative chemo, 83 versus 56, and fewer patients underwent surgery. And as we'll discuss later, there's sort of a lot of debate around whether TPN helps or hurts or whether it makes any sense in people with complete bowel obstruction. So I just want to lay out there the fact that in their data, 27% who received TPN did survive more than 6 months to 2 years. And I know hospice in our country at least does not allow you to be on TPN. It's too expensive. And so it's often like a branch point in an ovarian cancer patient's trajectory, whether you stop the TPN or not. And as palliative care clinicians, I need you to know that there is a quarter of patients who've had malignant bowel obstructions who do survive, for prolonged periods of time. A quarter of them had catheter complications, mostly infections, but it kind of goes counter our idea about TPN in people with advanced malignancies. So I thought this data was really helpful. Now, at our hospital at Brigham and Women's, and in our collaboration, we thought, well, we need something more systematic also, because in palliative care and GI surgery, we all closely collaborate in the care of patients with malignant bowel obstructions, but it was kind of hit or miss depending on which doctor you got and if they were old school trained, right, or new school trained, what happened. This kind of data is very inspiring. We can't put together a team like this, but we did put together a protocol that we have published on, and I'm more than happy to share. Colleen was instrumental in this. So I thought I'd share the protocol with you, and then we could certainly ask questions. Okay. This is difficult to read. And I have a rule that says you can't put up a slide that's difficult to read, so I'm going to read it to you. The blue circles is just introducing somebody into the pathway. The diamond is a decision point. And where you see a green circle, that means that the person has exited the pathway. So in the beginning, as somebody enters the malignant bowel obstruction pathway, they have to decide, like right away, is there an emergency that we can't go through the pathway? There are exceptions to being on it. But then there's smart phrases that create orders for all the things that we talked about, and that answers your question about do we order everything at once or do we wait for things? So the medication bundle that's part of the smart phrase and part of the orders, we have physician assistants caring for many of these patients along with other oncology hospitalist teams. They will get dexamethasone, they'll get opioids as needed, they'll get metoclopramide if it's partial, olanzapine for nausea if it's a complete obstruction, and glycopyrrolate if there is significant cramping.
And I'm going to interrupt you for a minute because in a teaching hospital, one of the problems that I saw was that I had residents rotating through every 4 weeks. And we would have someone come in with a bowel obstruction, and it was toss it up in the air what somebody got, because the residents weren't taught well about bowel obstruction. And this really changed our ability to be more consistent with folks and more thoughtful about how women, in my specialty, were treated when they came with a bowel obstruction. And then also starting to think about sort of the bigger picture. And what we'll start to talk about is, because as a surgeon, what I saw, and we'll talk about in the next slide, is just so many women on the wards for weeks and not enough getting done. So this was sort of the standardization of how we approach somebody who comes in with a bowel obstruction.
We started the protocol just with the women's cancers because it was small enough that we could do a pilot with them. And, but when the PAs learned about it, and they learned about the smart phrases, it quickly spread. We don't have data on efficacy, but we do have data that the use of dexamethasone increased remarkably with this protocol without any adverse effects, and in fact with good effect. And we also have some data that, as we'll discuss later, the goals of care conversations occurred that were not occurring before. We did find that sub-Q octreotide was not pleasant, which we knew for patients, and so they weren't using that. But when we offered it intravenously, then they adapted the protocol to that, and it worked just as well. So we learned a lot, and I would say the corticosteroids were the big new thing. On day one, we consider NG2 placement, and we consider paracentesis if a large volume of ascites. Sorry.
That's okay.
Here's Colleen.
So continuing the story of our case, our patient was admitted and entered the malignant bowel protocol. An NG tube was placed, and we started our usual routine. On hospital day 3, she was still putting out a fairly high amount and not really improving, not really passing gas. And so this was very typical. And prior to this protocol that we developed, I used to see this a lot, only it could be now day 10 and nothing had been done. And so we started to think about, okay, in this particular patient, what should be next? And I don't know if there are other either surgeons or medical oncologists out there and you're looking at this thing, all right, well, do we start thinking about something hospital day number 4, or do we not start thinking, what are you doing at this point?
Any volunteers? We had a question over there, but
Yeah.
Hi there. My name's Lana. I'm a palliative care physician from New Zealand. I just had a question about the use of olanzapine, just going back to your previous slide about using that as first line for complete obstruction. It's not what I'm familiar with, and I wonder if it's due to drug availability in your countries. So.
oh, I see. So for nausea, we have haloperidol.
Yeah.
I don't know if you have that.
Yeah, so we would usually use haloperidol,
Yes.
levothyroxine.
And I think in other situations, haloperidol was used.
Yeah.
Our patients, we have free availability of olanzapine, it seems, and
Is this injectable olanzapine?
it's injectable.
Okay, we don't have that. Okay.
Yeah, and it does help their anxiety quite a bit, as well as the nausea. It has less of a stigma in the U.S. Haldol has a bit of a stigma. I don't know if those of you who are also, that families are kind of nervous. If you say you're going to use Haldol for nausea, they've heard about it for serious mental illness. And so I think that's probably why we went to olanzapine instead of haloperidol.
Okay, so not any sort of solid evidence that it works any.
No solid evidence whatsoever. More evidence using haloperidol.
Yeah.
In Australia, especially in all of Australia, New Zealand,
Yeah.
Canada probably too, I don't know. But certainly Australia and New Zealand, haloperidol is part of the protocol.
Yeah.
Thank you. So anybody want to come up and say what they're thinking or what they would do?
What they would
Yes.
consider, yeah.
What they consider? What else you want to know? I guess we can also move ahead. I don't see. Yes, I see a hand. Sorry, can you come to a microphone? I don't know where. Is there only one?
Yeah.
Thank you.
So I think in this case, if they don't have ascites and if, considering surgical options, so from my understanding, the consideration of a venting G-tube, if there is no further cancer-directed treatment, that might be feasible, and that would give them the ability to continue to eat and drink for comfort. Alternatively, I have also heard that at Sunnybrook Hospital, they offer something called a PTEG, which is a percutaneous transesophageal gastrostomy, something related to that in the cases where there is ascites. I've not.
Yeah, we will be talking about other procedures later, so those are
Yep.
really good ideas. Just
Yep.
to mention that a venting G-tube does not allow people to eat. It only allows people to drink clear liquids. Just to,
Technically.
so, so wouldn't it be wonderful if we had something that would allow people to eat? And we'll talk about some other techniques that might allow people to eat, but unfortunately a venting G will not. But thank you for the idea of the other procedures. But we will be getting to other procedures later, so thanks.
I forgot to mention that at this point, if the oncologist and the surgeon has not already been involved, that would be a good time.
That is such a good idea.
So those are, I mean, and obviously not everyone knows a lot necessarily about ovarian cancer and this particular patient. So I think to frame this, we're talking about someone who's had a 2-year interval. She did well with her chemo to start with. This is her first recurrence. And a lot of folks might say, oh, well, chemo or surgery. But the elephant in the room is that this is a recurrence of ovarian cancer after 2 years. And the likelihood now is for this patient is she will continue to have recurrences. So almost no matter what I do, I'm not going to cure her. And that's a really important part of this to think about. And so while I could, as the surgeon, say, the right answer is I go back in, I take out this tumor, she gets chemotherapy again, she's going to be fine. And the likelihood is actually she will be for a period of time. So I think what we want to say here is to sort of think about this is a stop point for us to talk to our patient. And this is where we talk about day 4.
And I know some of you may think, how could you, it's only day 4 and it's her first recurrence. I just want to say this makes me feel so good about how palliative care has infiltrated our hospital that everybody was okay with us having this discussion at day 4. And we're not talking about DNR here. We're not talking about code status, but we're talking about hopes and worries and what's acceptable, especially for young women and their bodies, and how much ovarian cancer changes their bodies, and the whole idea of having something coming out of it, you know, or having to have a tube in it, or there's just so many issues around body images with especially young ovarian cancer patients. So we all felt, the surgeons, the medical oncologists, and we all felt it's very important when you're at a branch point and could offer things, let's find out what the hopes and the worries are and what would be acceptable, because we can do what the patient wants. And that's when palliative care is definitely involved if they haven't been involved before. That's at day 4 we get them involved, because as Colleen said, it could be 2 weeks if we didn't have the protocol before somebody kind of realized, oh, I guess they're not resolving, you know, this isn't happening. So that's why we put it early.
And we're going to get a little bit back to this topic of that conversation, particularly involving a patient's surgeon, their medical oncologist, along with the palliative care team in those conversations, because I think it's really critical. It can, things can go sideways when you're not involving everyone and really understanding the context and the options, and situating the options in light of the patient and their priorities, and also medically what's kind of most appropriate. In terms of medical decisions that our pathway deals with at day 4 is, if the symptom's not improving, we add octreotide. We talked about nasogastric tubes. If one has not been placed, at this point we would place it. And then we talked about the consultation. And so I wanted to talk a little bit more about octreotide as an agent and how we use it. So the pharmacology, octreotide is basically a somatostatin analog. So somatostatin is a naturally occurring peptide that acts to inhibit the release of and also inhibit the action of a variety of different GI stimulatory peptides. So that would include like vasoactive intestinal peptide, glucagon, insulin, and a variety of others. And it acts to reduce secretion of luminal GI fluid and also increase resorption of that fluid. So we tend to start patients at sort of a low dose, so 100 micrograms twice a day, and then titrate up as quickly as, you know, every day, or we might start higher if someone's having really large volume output. Usually we stop around 300 micrograms 3 times per day. As was mentioned before, this is a subcutaneous injection. Usually it causes a lot of pain, it stings, but it can be given IV, and there's no reason not to do that. We monitor the volume of emesis and monitor NG output to see how well it's working. Once a patient sort of is ready to leave the hospital, if we're going to continue this medication, that's when we would give a depot version of octreotide. So there's a long-acting formulation that's given IM. It's also particularly painful, and it's important to know that octreotide LAR takes about 20 days to get to peak plasma effect. And so if you're sending someone out on that, you actually need to bridge them with ongoing sub-Q injections. And if you don't, they may have had dramatic kind of drop of their emesis, but if you don't do that bridge, then they're going to start having, much larger emesis and could come back to the hospital if you're not sort of bridging them for that period of time. Side effects that we routinely see kind of in the acute setting, thirst is a big one, so thirst or dry mouth, and then we mentioned pain. Longer term, and this may or may not be kind of something someone with a chronic long-term bowel obstruction, not all of these symptoms are relevant for, but I use octreotide a lot for patients with carcinoid tumor and carcinoid syndrome, and we always monitor thyroid function tests about every 3 to 6 months because it also inhibits release of thyroid stimulatory hormone. We monitor for hypercholesterolemia, and a big one that we see is cholestasis, and also lack of, it sort of impedes the flow of pancreatic enzymes. So patients get gallstones or cholestasis frequently, and for someone who's not obstructed, we actually see a lot of diarrhea related to pancreatic exocrine insufficiency. And the reason we use it is there is decent data. It's not the best quality, but there are more than 4 randomized trials at this point comparing octreotide to a variety of different interventions, most notably to anticholinergics, and they're superior in terms of relief of nausea and vomiting. And there doesn't seem to be any evidence from these trials that it sort of interferes with the ability to turn to turn an obstruction around. So these studies, either of octreotide by itself or in combination with other things, you can see upwards of 50, 60, or even more % of patients kind of having resolution of a bowel obstruction. Often it recurs, but short-term resolution can happen. Lanreotide is a newer agent. It's a synthetic somatostatin analog, and there is some data for using it. We don't use it in the US. I'm not sure. Does anyone use it here in Canada for bowel obstruction? We were wondering.
Yeah.
We were debating.
Oh, I saw one hand.
One hand? Okay.
Okay.
And
sure, coming to a pharmacy near you sometime.
I use it myself all the time for neuroendocrine tumors of the midgut and pancreas in particular, but we don't actually have FDA approval for bowel obstruction, so we don't use it in that setting. But it's a synthetic somatostatin analog. There are some differences between lanreotide and octreotide. So one is the receptor binding. So octreotide really almost exclusively binds to somatostatin receptor 2, whereas, octreotide, whereas lanreotide has a little bit more action against somatostatin receptor 5 and 3, and it has just slightly different impacts on things like blood sugar and glucagon, like insulin and glucagon actions. Clinically, we don't really see it to be that meaningful for this type of indication, but it can be for functional neuroendocrine tumors, for example. Really the two big differences. One, this has a much shorter time to achieve a maximum serum concentration, so only 7 hours versus the 20 days that we talked about for long-acting octreotide. So that means you don't have to have a bridge, and that would make it honestly really nice to have as available. And the other issue is this is given as a deep sub-Q injection rather than IM. And so the drug company that makes it actually kind of markets it around having less pain. And I don't know that my patients per se have said that it's that much less painful, but that is something that you will hear. We're talking about this because there was a randomized clinical trial of lanreotide for malignant bowel obstruction published in the Journal of Clinical Oncology about a decade ago. And I think this trial has its flaws, and it challenges just how difficult it is to do these types of studies. So it was a trial conducted across 4 different countries, 200 hospitals, and it took them 5 years to accrue to this trial. So this was taking patients with peritoneal carcinomatosis, inoperable bowel obstruction, patients who either had an NG tube or that were vomiting more than twice a day and that were already receiving IV steroids and PPI, sort of emphasizing this is part of a multi-drug approach to managing bowel obstruction. And patients were randomized to either lanreotide 30 milligrams or placebo. It's a very funny study. They withdrew patients if they did not have an NG tube, and an NG tube was inserted during the intervention. So it's very messy. And their primary outcome was looking at response, which was basically less than 1 episode of emesis per day, or not having to, or being able to pull an NG tube at 7 days. So really short follow-up, 7 days. And there are a variety of other secondary outcomes that they looked at, including pain, the volume of emesis or NG tube output, well-being, et cetera. And just to say that, so in that 5 years, it took 5 years just to enroll 80 patients, and yet they still excluded almost half of them. So in the end, there was about 50-ish patients to even evaluate data on. And overall, it didn't meet its primary outcomes. So if you looked at response rate at 7 days in their attention to treat population, there was no difference. If they looked in sort of a pre-specified per protocol population, which is subject to a lot of bias based off of pulling people out who had an NG tube placed, they did see a difference. And then if you look across the board at most of the other outcomes, there was no difference. There was difference in self-rated well-being favoring lanreotide, but no difference in vomiting and nausea, for example.
I just wanted to note that I think we only have about 15,
30 minutes, yeah.
25 minutes left. So
We'll try to speed it up.
we'll try to speed it up a little, but the most important thing is you'll have all these slides if you have questions. We don't want to discourage that. We just, if you find us speeding things up, that's the reason.
Go through this.
Yeah.
So I think I've already mentioned that at this point that with our patients, we're thinking about at what time do we bring together all of the key people on the team and discuss next steps. So I'm not going to dwell on it. We've sort of had this conversation a little bit.
Right.
Who are the right people?
And this is in the protocol itself, and the colorectal surgeons, the GYN-onc surgeons, the medical oncologists, whoever, and palliative care, whoever has the longest relationship with the patient are the ones who lead those meetings. And everyone agreed that, as we discussed, goals of care and hopes and worries of the patient and family are really important to identify at this point.
So just to update you, at this point we did hold a family meeting. I was involved. I don't always give my own chemotherapy. We involve medical oncology. We involve palliative care, the nurse, who's oftentimes been taking care of this patient, sometimes a caseworker, the families, and usually my fellow, right, who, we try to teach the next generation about this protocol and about also the types of patients that they'll see. So everyone was present. We decided that given her circumstances, her chemosensitivity, her long platinum-free interval, that she was in fact a surgical candidate. She did go to surgery. We resected again her tumor, and with the plan to do more chemotherapy. What I thought I would do is take a moment, because I don't know how many people here actually see their CAT scans in the hospital and evaluate whether or not someone's a surgical candidate or where they are in their disease.
Lots of people.
So it's interesting because nothing tells you what's really there. So for example, this is not my patient's picture, but this might be a picture that someone sees of a CAT scan in the setting of a bowel obstruction. And what do you think the surgeon sees? Oh my goodness, yes, there's this big omental cake. And while these can sometimes be resected and patient can go on and move forward with, it's not always the case. This can sometimes present as a proximal obstruction, as actually a gastric outlet obstruction. So this is just it kind of went backwards a little bit, but I mean, essentially we see, we see kind of these rings, we see fluid going through. It doesn't even look like an obstruction, and this is more of a functional obstruction. And what we see when we go in is that terrible disease that's infiltrating into the mesentery, that's obstructing nerve pathways and not allowing for motility. And then
the lead pipe thing?
That's
what do they call
that's
that?
the lead pipe. Yeah, this is the lead pipe syndrome, where even the gut looks more or less okay, but it's just not able to work effectively because the nerve plexus is involved.
I think that's why the pre-op conversations have to be pretty complicated, because being too optimistic, knowing though that what we saw in the CAT scan won't dictate what happens at surgery. I think all of us have to be prepared. All of her healthcare team had to be prepared for this patient. Even though we recommended surgery, we had to be prepared that we weren't sure what would happen when Colleen got in there.
And we'll touch on this as we go. I'll just finish this. Again, I thought it was interesting to show you pictures and then what really happens.
Yeah.
This is sort of every surgeon's nightmare. And this is where all of the bowel has been retracted, the mesentery is all retracted. We know that there's tumor infiltrating and tethering it all down. This is called cauliflower bowel. And when you go in, you see this horrible encasement of everything down. And there is, as you can probably recognize, there is no surgical option here for releasing this bowel obstruction. And I think this will kind of segue as we go on onto, what do we need to think about? And it may be different depending on the disease, depending on where someone is in their course, depending on what we think chemotherapy will do. But it's always interesting to sort of get the perspective of what the radiologist sees and then what the surgeon sees.
Yeah.
So we'll go on to another case.
I think that's invaluable. Thank you so much.
So this is just to emphasize when Dr. Feltmate or another surgeon is telling you, actually, I can't operate, what are the other types of interventions that we can offer that might palliate symptoms? So this is a patient, not her picture, but it's a real patient I took care of 5 or 10 years ago, a 62-year-old woman who had had a recent large stroke, a posterior circulation stroke, and in sort of the midst of her workup and treatment of that was found to have metastatic colorectal cancer, newly diagnosed. And now, sort of into her recovery post-stroke, she develops obstipation and abdominal pain. And this is representative of what barium enema would look like in her. So you see the white contrast sort of in the distal colon, and you see a nice apple core lesion, and nothing's getting past that. So she has a large bowel obstruction related to her primary colon tumor. So we'll imagine that we met with this patient's surgeon, and because of the need for anticoagulation, her ongoing recovery, really, she's not a candidate right now for a resection and treatment of that. So this is a type of patient where we'd want to think about non-invasive interventions that could help. Luminal GI stents would be the main category. So this patient has a colonic obstruction, so there are stents that can be placed across the colon. I also see them often used for proximal obstructions at the gastric outlet or in the duodenum. And these are basically self-expandable stents that endoscopists can place, and then they open up the obstruction and can really cause very immediate improvement in symptoms. There are a number of complications to be aware of, and so not leading a patient to think this is a fix-all. So migration of the stent is huge. Now for a patient with a colon tumor, if it migrates, they just sort of eliminate the stent, and it's not that big of a problem necessarily. But for a stent that's higher up, it can migrate and it can actually perforate, or it can cause another obstruction because of that. They can cause bleeding, perforation, and if the tumor grows through the stent itself, then that you can have recurrence of the obstruction. As an oncologist, I think about this if someone's untreated, or I think they have more treatment options left over, kind of left after this. This migration issue is a problem. So if I'm giving them chemotherapy, if it actually works and the tumor shrinks, then that stent is gonna migrate. So we typically would want to remove it before attempting that. There's a newer option that we're seeing a lot in our hospital, and I'm curious to know if it's being used in Canada, but there is a company that makes this particular type of stent that's made to basically replicate what would be done in a like a colonic or just a kind of a bypass surgery. So instead of having to cut the patient open and take a loop of bowel past the obstruction and connect it up ahead of the obstruction, what the endoscopists do, if there's an obstruction early on, is they will try to place a stent that goes between the stomach and then some place further down in the small bowel below the level of the obstruction, and it creates a bypass. The level of data with these is not great at this point, but evidence does suggest superior outcomes to duodenal stents with lower rates of recurrent obstruction and migration. I will say I've had several patients where these actually migrated, and I had one patient where it ended up creating a connection between the colon and like the distal small bowel, which is not what you want to happen. But these can be effective, and actually an advantage of this is patients are able to eventually, after a few weeks, kind of get back onto somewhat of a diet. So
Usually like a full liquid diet, right?
Yeah, and sometimes they can actually get to sort of full liquid or even soft solids.
Yeah, so again, if you're part of the palliative care team for expectation setting, it's really important the patient knows that what your goal, I mean, your gold standard would be soft solids, if maybe, but often pureed, or because otherwise the scent just clogs up. So that's the best. But if they can drink or have full liquids or soft solids, it could be a huge win for socialization.
Yeah.
You know, they can go out to dinner with everybody, and just like when you go out to dinner with a person who's just had all kinds of dental stuff and their jaws wired together and they have to have smoothies or something, you know, the person can certainly continue with a soft solid or a full liquid diet and socialize. It makes a big difference.
Yeah. So for this patient, she did have a stent placed and it enabled her to have some quality of life. We thought we were going to take her to a resection later, and she really actually declined and ended up receiving hospice and passing away. But it was an effective palliative intervention for her. This is another patient I took care of, not his picture, but a real man that I think of very fondly, to illustrate kind of other types of interventions we think about. So it was a 48-year-old who had a peritoneal dissemination of signet ring adenocarcinoma. So we often see this either from appendiceal cancer, sometimes gastric, and often just unknown primaries. And he presented with several weeks of high-pitched bowel sounds, anorexia, weight loss, 3 days of nausea, vomiting, and obstipation. So concerning for a bowel obstruction. And a CT scan confirms an obstruction with really a more multifocal and diffuse pattern, not a clear, single obstruction, easy to sort of bypass. So he was treated on kind of our protocol. And at day 4 and beyond, he really isn't improving. So still more than a liter out from his NG tube daily. And we have a family meeting with myself, with a colorectal surgeon, palliative care team, and it's decided that unfortunately he's not an operative candidate because he has this sort of diffuse carcinomatosis. So at that point, we really want to be thinking about other interventions that might be helpful. And we'll probably have to go through this relatively quickly.
Yeah, basically the endpoint has to do with having discussions involving the prognosis initiated, as I was saying before, by the patient's longitudinal clinician. So that would vary depending on who it is. And so I'm having trouble reading it too, so I have notes. So the green circle again is where the patient doesn't. The first diamond says, are there interventions possible? And again, this is after quite a while. This is the end of the protocol. If there are no interventions possible, then we discuss more about prognosis and other symptomatic therapies. But if yes, then we do find out what the prognostic estimate is, and would this meet with the patient's goals of care again? This is all about, depending on what the intervention is, whether it's acceptable to the patient and the family. And if an intervention is acceptable, then we proceed with the intervention. If it's not acceptable, then we go ahead with focusing on comfort-focused care. But the patient is always at the center of our protocol. And I think that's what makes it a little bit different than most protocols, and one that I'm excited about as a collaboration among all of us.
So for this patient, he's still having pretty profound large volume emesis that's impeding his quality of life. So I think we already had someone mention the idea of a venting G-tube, and we kind of want to think about, is there a way that we can avoid sending him home either with an NG tube, which is awfully hard to do, or having him vomit large volumes multiple times per day. So kind of considerations for practitioners, there are several different ways you can place them. Obviously surgical, usually that's happening if, let's say, Colleen is taking a patient to the OR, isn't sure, like maybe I can do a bypass, finds out she can't, so she would place a venting G-tube at that point. But usually you wouldn't want to go with the most invasive route to do a venting G-tube if you have other options. So interventional radiology often places these percutaneously, and essentially you put down an NG tube, you insufflate the stomach, and using fluoro, they're able to kind of identify a good window from the gastric air bubble and just punch a hole right through. And then you can do the reverse endoscopically. So go down with a camera, you insufflate the stomach, you transluminate, try to look at the light, and you punch the hole through. And so kind of involving the right colleagues and deferring to them about the best approaches. There are a number of contraindications we should think about. So ascites is a relative contraindication. Really the danger is that you can't get the stomach wall up close enough to the abdominal wall, and you can end up with leakage around it. Now, if you have large volume ascites, it's not gonna work, just forget it. A major thing I deal with in GI cancer is just having tumor that's right where you need to go. So it's between the stomach and the abdominal wall. You don't wanna be punching a needle through there, it won't heal. And that's an absolute contraindication. Or if you have the entire stomach really being involved by tumor, same problem. And then for IR endoscopic, if you don't have a good window, so if you have varices that are sort of where you need to go, or the colon is kind of in front of the stomach, or there's some other anatomical issue, those would be contraindications. And to mention, there's so much self-care patients have to do, and that's where these goals of care conversations and helping them patients understand, what are you signing up for? Like, this isn't, you can, then go home and eat. Really don't want patients eating anything beyond clear liquids, maybe occasional full liquids, because the tubes get clogged very easily, and that's its own set of problems. Requires regular flushing, a lot of troubleshooting at home. And being attached to this thing. Often people really can't go home without the bag and having it open all the time.
Though again, when it does work, it's
wonderful,
and it again, sometimes along with octreotide. Venting Gs along with octreotide can make it mostly that you can cap it with flushing it. And again, for socializing and so forth, it just makes a huge bit of difference.
So back to this patient. So we were actually unable to perform the venting gastrostomy. It was too high risk surgically. There was not a good window for the radiologist to do it percutaneously, and our gastroenterologist attempted, but basically the stomach was just an iron sac. Like there was no way to insufflate it, no way that they could actually transluminate and get this through. So now we're dealing with a patient who has really a complete bowel obstruction and no options for palliating the vomiting that he's having. And we have a little more than 5 minutes left, and so I don't want to belabor the point, but kind of comes up with the real kind of pickle, sort of the elephant in the room.
The elephant in the room.
TPN, and like, when do you do it, when don't you do it? And I think maybe for time we'll sort of talk a little bit amongst ourselves through these and thinking about clinical factors that weigh into this decision or not. As an oncologist, I really want to think a lot about what treatment options they have left, if I'm even going to try to do treatment, because chemotherapy often causes, nausea, vomiting. That's made much worse by bowel obstructions. What's the pace of their disease been over time? Is this something that I'm seeing growing scan after scan, or is this something that's been pretty steady and sort of slowly moving or indolent? Do they have other sites of disease? Do they have a liver that's mostly replaced by cancer and it's a matter of time? Or is this really isolated to the peritoneum and that is the primary problem?
Right. Obviously, caregiver factors are huge because the family has to do the TPN, and then the patient has to get blood draws frequently. So there's a lot of burden. There is some risk in terms of infection. I explained that it's like when you feed fish in a fish bowl and the bacteria, kind of come to where all the food is going. But I would say the main problem is the responsibility of the caregiver and the burden on the patient of all the monitoring that goes on with TPN.
Financial logistical things, particularly in the US, it's hard to get TPN approved with hospice, and so we know that's the best quality of life promoting care that we can give, how do you make that trade-off, and how do you make that clear to the patient and the family when you're considering it? And then also just thinking through, if you start this, then what happens? It's sort of sometimes a bridge to nowhere, and how do you then support a patient and family if they choose to start this when the time comes really to stop it?
Unlike this patient, often it comes up with a small bowel obstruction and ovarian cancer patient who actually would benefit for 3 months or 4 months, but then wouldn't benefit. And if hospices would allow, and if you knew the prognosis for 6 months and you could, and they would allow the TPN until it wasn't helping the quality of life, wouldn't that be wonderful? But the amount of money they get paid for each patient in the US is so little that they couldn't afford to give TPN to all the patients who might actually benefit for a prolonged period of time with it. And we can again discuss this offline later.
And just to end with, I think I'll end with this slide, but actually this is a real patient of mine, one of my first patients I had as an attending. And even though it seems pretty dire, he actually had on imaging kind of cancer wasn't growing over time. He was young, he had a good performance status. Really, this was the only problem he had. I mean, it was a huge problem, but he didn't have disease also. And we actually kind of carefully decided to try TPN, and he lived for 2 years with a good quality of life. I mean, I was very close to him and his family. I remember for his 50th birthday party, they did a buffet of different juices. No one was allowed to bring food. It was really hard for him to watch it. And he learned he would bring his vomit bags with him, and he vomited 4 or 5 times a day easily, but it just got to be to a point where he was able to manage that. And it was actually quite beautiful. They were a very religious family, and they kind of struggled at the end with sort of the thought of letting go and feeling like they were giving up on this idea of a miracle. And we had, by that point, such a close relationship. We were to talk about, like, how do you know if you're actually starting to die now? Nothing else is changing. I didn't give him chemo, but how does he know that it was his time to then stop the TPN and switch to hydration only? And he knew, and he told me, and he helped get his wife there, and it was really beautiful. So it actually ended up being quite peaceful, and the thing that I was particularly worried about, like if I start this, I'll never be able to stop, didn't happen. And he was able to die with hospice, surrounded by the people he cared about, and he had a good quality of life for that period of time, even though really our interventions were minimal. So I think we are really out of time, but just to wrap up, we're hoping that we covered our objectives, and we have 1 minute, but thank you.
Thank you very much.
Thank you so much.
Thank you. So I would like to thank our speakers for today, and very, very much appreciated. We have the time for one question, one question only. Here we go.
Thank you very much for your presentation. I guess I am an advanced practice nurse, so my deference to the oncologists and the surgeons and the physicians, but coming from this from a palliative care lens, because that's my perspective, I guess I wonder, why wait to day 4? Why aren't we having goals of care discussion right at the beginning, before interventions are tried, before anything, to say to the family, as Kimberly said earlier today in the plenary, that idea that there is an intervention, which is palliative care. So that's my curiosity.
Okay.
Thank you.
Please clap. Yeah. I think that the reason we didn't put it in day 1, though certainly if the person were going to go to surgery, that would be part of day 1, was that we wanted to involve the patient fully. And we were concerned that most of these patients were in terrible pain, had been vomiting, were exhausted, weren't sleeping, that it would have been hard for them to participate as fully as they wanted, and to rely on their families when they still had capacity didn't feel unreasonable, because the interventions were medical interventions. It's true, they were interventions, but they were not and they were minimally invasive, I would say, because they didn't involve much other than an IV line. But that was there was an interdisciplinary team that I think I mentioned involving nurses, dietitians, pharmacists, all the medical people you heard about, social workers, and that was the decision, if that helps you understand why we waited to day 4. But I do hear your point. Thank you for that.
Yeah, and I agree with you. I think that a lot of hang up in the US maybe is just the term palliative care.
Yeah.
People think that as soon as you mention that they're dead. I mean, and it's very, you know, we have long conversations, I don't know if you do as well, in my clinic about palliative care is not about dying, it's about symptom relief. And sometimes it can be about the end of life as well, but that's not necessarily what we're talking about when we say palliative care. So I actually try to start the conversations quite early, but I don't think that's true of everyone.
No.
So thanks again for all the very multidisciplinary approach. Thank you very much.
Thank you.
Thank you.
And just for the accreditation, and just to remember to do your evaluations on the app, and the individual call of the session is 1726 1726 if you want to have your credits. So thank you very much, and see you in 30 minutes.
We've had a few residents I know that we've texted them.
Nice meeting you in person. Now, I was just going to say to Jonathan, I'm going to say hi again and present myself again. On Tuesdays, my brain is scattered.
No, they didn't. But from the description, it looks like they start their octreotide on day 4 if things are not getting any better for purposes of symptom reduction, and then they keep it going forever, and they discharge them on it. And I'm like, yeah, that's not going to happen.
Well, it's too expensive.
Yeah.
They get the LR.
No, well, they give the LR.
Lanreotide.
But no, Lanreotide. It's available in Quebec. It's covered.
No, it is. Lanreotide we can get.
It's $1,000 a dose per week.
It's per week.
Lanreotide.
I have a lot of patients on Lanreotide because I follow my oncologist, endocrine tumor patients. So I do a lot. There's actually patients I get on buprenorphine, by the way. They do amazing. But the thing is, other than them, like I have not been able to get I haven't prescribed Lanreotide, and I still don't understand where they use it. Because I find when people open up, they don't close up right away. Like you don't find that when they open it, they open up, and so it's not like they're suddenly gonna close. So I always find out that I can usually win. Yeah, exactly.
That sounds like a nice medicine at home.
The Lanreotide. And what I'm even thinking, I haven't seen it, but I'm wondering if we should do like octreotide, then send them home with Lanreotide for maybe like 2 weeks while the long-acting takes effect over 20 days or something.
For the octreotide?
Because the octreotide long-acting
Oui,
takes
c'est ça, ça prend 20
to
days.
kick in, but I wonder if Lanreotide should be, again,
But if the person is comfortable with that, you could just continue that.
But it sounds like that's really for again, it strikes me that the octreotide and the Lanreotide are much more for nausea and vomiting for patients who have or at least partial obstruction, like they're ongoing partial obstruction and are continuously symptomatic. Sorry? With the
Partial or complete?
What? Partial? Complete.
In hospital, you mean?
He was in the hospital, he got in the ER, we started the
Is this on? Oh, it is. Hello, good afternoon. If you are here for the nursing session, we are very happy to have you. Could I invite you to come maybe closer to the front? We are in this room so that we can have simultaneous interpretation. I doubt that we're going to fill the space, so come up.
Good afternoon. I think we're going to get started. Thank you so much for joining us for the last of the nursing sessions today. It's good to see you all here. My name is Jamie Penner. I'll be moderating the session this afternoon. Just a few items of housekeeping before we get started. For those of you just coming in, please come to the front, come forward. That would be great. Join us up here. I will remind you at the end again, however, if any of you need to claim accreditation hours, the code for this afternoon session is 1737, so you can go onto the app to enter that at any point. Okay, so it is my great pleasure to introduce our speakers for this afternoon. We have a bit of a unique format this afternoon. So we're going to have three slightly shorter presentations, but these were submitted abstracts that were carefully chosen and curated for this afternoon's session as the topics really related well to sort of our theme for the week. And very interesting topics. So we're very much looking forward to hearing those. And following that, we will have a 45-minute presentation as well, focused on compassion in nursing practice. So I'm going to introduce the first three speakers and presentations. So it is my pleasure to introduce Gloria Carrillo. Did I do okay with that? Okay. Gloria will be speaking about the use of nursing narrative as a learning strategy in palliative care. This presentation will be followed by Maxime Rifad and Guillaume Novembre. And I don't speak French, so I'll say the title of their presentation in English, but they will be presenting in French today. So their presentation will be exploring the lived experience of nurses accompanying palliative patients at the end of life in Lond. And the third presentation will be by Stephanie Liversidge, and she will be speaking about Help is a Phone Call Away, a 24-hour nurse-led pediatric hospice clinical care line. So I will invite Gloria up to the stage.
Good afternoon. Thank you for this opportunity. My name is Gloria Carrillo, and my presentation is use of nursing narrative as a learning strategy of palliative care. We don't have conflict of interest related to this presentation. I don't have any affiliation with any not or profit organization. My competence framework is scholar. My work is related to teaching and learning nursing. What is the learning objectives? At the conclusion of this presentation, participants will be able to recognize the importance of the use of narratives as a learning strategy in palliative care that, based on reflection questions, facilitates understanding the importance of valuing the role as a professional caregiver, appreciating and attributing meaning of life. What is the introduction? The global need for palliative care will continue to increase as a competence of the growing burden of chronic diseases and the aging process of the population. In Latin America, only 7% of patients requiring palliative care receive it. Colombia is no exception. At present, palliative care is most frequently received by people with cancer and is concentratable in the most populated cities. In more distant cities and rural regions, it is insufficient. The lack of training and awareness of palliative care among health professionals is a major obstacle to programs to improve access to palliative care. Excuse me. Multiple challenges have been identified of the training of healthcare professionals. The emotions that can be experienced by healthcare staff without palliative care, trained care, frustration, fear, anxiety, and depression. The teaching of palliative care in nursing requires that the use of pedagogical strategies that allow students to learn a meaning of reflecting way. The use of methodological tools such as one proposed by Smith and Lyer, which with the use of narratives of nursing situation lead the participants in an introspective, analytical, and deliberative process regarding their role as caregivers. What is the objective of this project? To explore the effects of the use of nursing narratives for palliative care learning in nursing students. The method is that design MIPCC method and with pre and post questionnaires and focus group discussion after the narrative-based experience. Participants include 18 nursing students from advanced semester who attend the module for 6 weeks, had access to 4 narratives, recognized the care needs, developed the nursing plan, and developed a guide about their experience as a caregiver. The strategy was designed as a part of an optional course in palliative care offered by the nursing faculty in my university. Exclusion criteria, only students diagnosed with depression who were being treated with the university welfare division. In the method, before and after the course, they complete a questionnaire that determines the perception of competence for palliative care. It includes 6 categories ordered under the acrostic with that in Spanish, is the means care in English. First, knowledge. C is a knowledge, uniqueness, personal condition. I, instrumental. D, well-being, in Spanish is disfrutar. A, anticipation, and R, social relations and interaction. They also participate in a focus group that's so to identify the perception of the use of the narrative. The strategy is specific is an interactive online course, a module based on nursing narrative about palliative care. 4 sections is one with a narrative and include analyze knowledge patterns in specific ethical, personal, empirical, and aesthetic. Narrative is an authentic case scenarios where construct through collaboration with clinical nurse in palliative care to facilitate the development of a nursing intervention plan. Each session includes a forum with open questions about the experience, satisfaction, and aspects to improve. It's an strategy include 4 narratives. The first narrative is Baby No More. Topics to be discussed: the role of nursing in palliative care, empathy, reciprocal interaction, communication until the end of the life. Second, Lucia, Princess of 1,000 Barrels, include palliative care in children, access to palliative care services, interdisciplinary communication, and teamwork. The Call of Inez is the third narrative, include physical pain, spiritual suffering, non-verbal communication, and the wall of silence. And Julie, Walk Again, include empathy, hope, nursing ground, and comfort. Is the example of the narrative Baby No More. This narrative is of Nelsie Montes in a nursing services palliative care in children in the Institute for Cancer in Colombia. One phrase: as I left the institute, I have certainly set our me. I believe that the young girl would not survive the weekend. When I returned on Monday, my first question was, is she still here? They replied, yes, she is still here. It felt like agony. I couldn't stand understanding why such a young girl had to endure such much suffering. In that moment, I thought maybe it would be better to her to let go and find peace. I went into her room and softly told her, baby, no more. The life you have is over. Go to the other side. She looked at me, smiled fondly, and I left, tears streaming down my face. A little while later, the auxiliary came to me and said, she's gone now. In that moment, I feel a deep connection with her, as if we had shared something profound. I learned that life is fragile, determined by forces beyond our control. And as a nurse, my role is to support these souls until their very last breath. In the results, the competence for palliative care, before the global competence for palliative care, in each of these components was scored low by students. After in the implementation of the strategy, the students reported high levels of global competencies in the components of knowledge, uniqueness, instrumental, and well-being. All the dimensions of the competence of palliative care significantly increased, and this change was statistically significant. And the most important results is knowledge patterns. The transversal analysis of the narratives allows us to see that in all cases, situations are identifying with nursing is life as a care, inspired by a reciprocal vision. The process of caring for the cancer patient and his family, despite being emotional hard, allows the growth of each of the people involved. This shows that allowed is a highly technical care. It has very hard and evident components on humanization. In the personal knowledge, the student reflects on the expression of authenticity of being genuine with a turn of is essential for a caring relationship. In empirical, the students, empirical pattern students derive a care plan from each narrative based on scientific evidence, which is common to make a care plan. Unethical, students analyze the ethical decisions derived from the narrative, recognize the expressions of values and principles of palliative care practices, and and in the aesthetic pattern of nursing art, the students recognize the artistic act in the act experience that means down what should be done at the right time, achieving mutual growth between the patient and the nurse. In focus group, We identify high satisfaction with the strategy and considers that the topics are pertinent, the methodology and the time management for developing them all was adequate. As most positive aspects identifiable by the students, a permanent reflection, the strategy contributes to their professional and personal perspective for reflection questions that allow them to understand the importance of the value in others, appreciating and attributing meaning to life, and the testimonials of nurses through the narrative experience that allows to think about different health situations, illnesses, and death of patient, as well as the importance of nursing, of using words and nonverbal expression properly and in the right scene. In the conclusion, the inclusion of meaning learning methodologies in a palliative care setting for facilities improve students' confidence, knowledge, skills, and attitudes. The knowledge patterns represent a structural perspective of the body of knowledge required to underpin palliative care nursing practice. All knowledge is subject to change in revision. Of course, practice deserves the same treatment. Each solution to a problem suggests new concerns and raises new unsolved problems. Thank you for your attention, and excuse me about my speaking in English, but thank you.
Bonjour à toutes et à tous. Nous vous remercions d'être présents aujourd'hui pour cette présentation et allons vous présenter notre travail de thèse que nous avons réalisé avec Maxime. Hop. Je ne sais pas si le diapo peut... Ouais. Donc Maxime et moi, nous sommes deux médecins généralistes qui travaillons dans le sud-ouest de la France. Maxime il s'occupe des lits de soins palliatifs du service de gastro-entérologie de l'hôpital de Mont-de-Marsan. Et moi, je suis médecin généraliste, donc general practitioner en France, dans une petite ville. Donc nous allons vous présenter notre travail de thèse qui consistait à explorer le vécu des infirmiers dans l'accompagnement palliatif à domicile dans les Landes. Nous n'avons pas de conflit d'intérêt à déclarer. Et les objectifs d'apprentissage de ce travail, ça va être d'abord de comprendre le vécu des infirmiers en France dans les situations palliatives, comment est-ce qu'ils vivent ces prises en charge palliatives, identifier les problèmes qu'ils peuvent rencontrer avec les médecins, notamment les médecins généralistes, et essayer de mettre en place un projet de soins en conclusion de ces difficultés pour essayer d'améliorer un petit peu les choses. Vous trouverez là les référentiels des compétences suite à notre travail. Donc pourquoi cette démarche de recherche? En France, on a vu suite à pas mal de sondages que 80% de la population souhaitait mourir à son domicile, ce qui n'est pas le cas en pratique. Il y a de nombreux travaux qui existent sur les problématiques du médecin, mais nous, on pense que l'accompagnement palliatif, c'est un travail d'équipe qui se fait pas seul, pas que avec le médecin, mais aussi avec les infirmiers. Et c'est pour ça qu'on voulait travailler sur une prise en charge plus globale pour essayer d'améliorer les choses. L'objectif principal, donc, c'est de vous expliquer le vécu des infirmiers dans la prise en charge palliative, et l'objectif secondaire, d'essayer de trouver des solutions à tout ça.
Alors, je vais vous faire un petit point géographique sur la situation des Landes, parce que c'est pas forcément connu de tout le monde, même si c'est un très beau coin de France. Donc déjà la France, bon, je vous fais pas l'affront de vous dire où c'est, de l'autre côté de l'Atlantique, ici, comme on le voit. Et le beau département des Landes, donc, qui est le plus grand département de France, mais qui est aussi un des plus ruraux, avec, voilà, comme on voit, une densité de population qui est vraiment plus basse que la moyenne française, avec un fort patrimoine culturel. Donc je vous explique très rapidement un peu l'organisation, pour ceux qui ne la connaissent pas aussi intuitif que ça. On a commencé un petit peu à regarder comment ça se passait au Québec et dans le reste du monde. C'est vrai qu'il y a une vraie différence. Donc on va prendre l'exemple vraiment du soin palliatif pour vous expliquer ça. Donc on a un accompagnement qui se fait à l'hôpital et un accompagnement qui se fait en ambulatoire, c'est-à-dire en ville. Alors en ville, à la campagne, mais en dehors en tout cas des murs de l'hôpital. Au sein de l'hôpital, il y a des structures qui accueillent les patients en hospitalisation complète, qu'on appelle les unités de médecine palliative, les UMP, et les lits identifiés de soins palliatifs, où je travaille. C'est vraiment les services de référence pour accompagner le patient quand c'est pas possible au domicile, de le faire à l'hôpital si jamais il y a des complications, etc. Il y a une équipe un petit peu transversale qui intervient dans les différents services, ça existe partout ailleurs. C'est les équipes mobiles de soins palliatifs qui ont un regard expert et neutre sur certaines situations qui sont compliquées dans les autres services à l'hôpital. Alors, voilà où ça se complique un petit peu. En dehors de l'hôpital, il y a différentes structures. Nous, on s'est vraiment focalisé en fait sur les infirmiers qui travaillent, ce qu'on appelle en libéral. Donc en fait, c'est des professionnels qui sont entrepreneurs, si on veut, qui sont à leur compte, et qui travaillent au sein de structures qu'on appelle des maisons de santé pluridisciplinaires qu'on trouve, vous regardez tout à droite, au niveau des CPTS. En fait, ils interviennent chez les patients, ils sont payés par la sécurité sociale, mais c'est vraiment, ils travaillent à leur compte en collaboration avec les autres professionnels de santé, mais c'est un peu à leur bon vouloir de pouvoir travailler avec eux. Il y a d'autres structures qui existent dans l'accompagnement palliatif. Il y a l'hospitalisation à domicile, qui en fait, c'est des infirmiers qui sont salariés, qui dépendent pas uniquement du médecin généraliste, mais aussi du médecin coordinateur de l'HAD. En fait, c'est l'hospitalisation à domicile, c'est l'hôpital à la maison. Il y a d'autres infirmiers après, il y a d'autres structures, je vais passer rapidement. Les services de soins infirmiers à domicile, les SIAD, qui là aussi, c'est des infirmières qui sont salariées, qui interviennent à ce niveau-là.
On a un peu planté le décor du territoire où on exerce. Maintenant, on va vous présenter plus précisément notre étude. Donc, c'est une étude qualitative, c'est-à-dire qu'on est allé rencontrer des infirmiers, des infirmières aussi principalement, pour leur poser la question de savoir qu'est-ce qu'ils éprouvaient et comment ça se passait les prises en charge palliatives. Pour ça, on a créé une grille d'entretien pour réaliser des entretiens avec eux, d'après la bibliographie. Et la population de l'étude, c'est-à-dire les personnes qu'on a analysées, c'était des infirmiers qui travaillaient soit en maison de retraite, soit en libéral, comme vous a dit Maxime, donc à leur compte, qui travaillaient avec un médecin généraliste directement sous son, je ne vais pas dire contrôle, mais en collaboration avec lui, entre guillemets. On a essayé de faire varier un petit peu les profils pour avoir un panel le plus représentatif possible. Donc on a essayé de faire varier le lieu d'exercice, les formations passées, notamment en soins palliatifs, les expériences professionnelles passées, et de répartir ça sur un peu tout notre territoire qui est assez grand et assez divers. Donc on a sollicité 20 infirmiers, bon il y en a 16 qui ont répondu, ça je passe assez vite. Donc les résultats, c'est là que c'est un petit peu intéressant. Donc vous trouverez entre guillemets, alors en français, je suis désolé pour les anglophones, en fait les transcrits des infirmiers, c'est-à-dire ce que nous ont dit et ce qu'on a mis tel quel sur nos diapos. Donc la première chose de cet accompagnement palliatif, c'est qu'on voit que c'est difficile, c'est une prise en charge singulière, différente des autres, que le projet de soin est vraiment centré sur le patient, qui va au-delà de la relation soignant-soigné. En France, mais je pense que c'est un peu pareil au Québec, les infirmiers sont vraiment très présents au domicile des patients, ils passent 2-3 fois par jour, tous les jours, pendant des semaines, voire des années, ils font presque partie de la famille. Et ça c'est difficile, ça rend les prises en charge très difficiles moralement, très éprouvantes, avec parfois la perte d'un patient, mais presque d'un membre de sa famille. On note aussi un manque de formation, un manque de temps, un manque de moyens, et on a ce qu'on appelle les directives anticipées en France, c'est un peu ce que vous avez au Québec aussi, où le patient peut dire ce qu'il veut au cas où il ne serait plus en possibilité de s'exprimer et d'exprimer ses souhaits. Et ça, c'est pas trop fait encore en France. On sait que ça existe, mais on ne sait pas quand l'utiliser. Et enfin, la spiritualité dans le soin qui pose pas tant de problèmes que ça finalement. L'accompagnement de l'entourage, c'est aussi ça qui fait que cette prise en charge est singulière. Il y a à la fois le patient, mais il y a aussi tout ce qui gravite autour. Et l'entourage, on le voit ici, ils sont considérés comme les aidants, des piliers du domicile, mais ça peut être parfois difficile quand ils sont dans le déni ou ils ne comprennent pas ce qui se passe. Et enfin, deux notions un peu différentes du Québec. La mort provoquée, c'est parfois des demandes qu'ils ont en France. Il n'y a pas de législation en France sur la mort provoquée. Ce n'est pas légal à l'heure actuelle. On a par contre de la sédation profonde et continue, comme vous, c'est-à-dire qu'en cas de symptômes réfractaires avec mise en jeu du pronostic vital à très court terme, on peut mettre en place des traitements pour sédater les patients jusqu'au décès. Il y a aussi des pistes d'amélioration finalement qui découlent un peu des problématiques qui ont été annoncées par les infirmières. Se préserver, parler entre infirmiers, en discuter ensemble, ça permet d'éliminer un peu les expériences, d'autant plus si elles ont été difficiles. Connaître le patient et l'entourage, c'est plus difficile parce qu'il faut les prendre en charge, mais d'un autre côté, ça facilite aussi, on sait ce que chacun veut et ce que chacun aimerait pour la fin de vie. La formation en soins palliatifs, on voit que clairement les gens formés sont plus compétents, ont moins peur et arrivent à mieux prendre en charge les patients. Ils ont besoin de quelqu'un qui guide la prise en soins, c'est-à-dire souvent le médecin généraliste, le general practitioner. Et enfin, ils ont besoin de prévoir et d'anticiper ce qui peut se passer. Les gens qui sont au domicile, parfois, peuvent décompenser certains symptômes et on peut faire des prescriptions anticipées. En gros, laisser libre cours à l'infirmier de démarrer un traitement sans forcément un nouvel avis médical si la situation se dégrade et que le médecin n'est pas disponible. Et ça va nous permettre d'ébaucher la deuxième partie qui est la relation entre le médecin et les infirmiers. Alors on voit pareil que dans cette anticipation, dans la prescription justement, il y a un manque d'anticipation où le médecin ne communique pas assez avec les familles, il n'y a pas de prescription de fait, ce qui met les infirmiers en difficulté. Et le gros point qui ressort, c'est qu'il y a encore une relation qui est hiérarchisée, où finalement le médecin, je ne sais pas si c'est pareil au Québec, mais peut pas forcément considérer l'infirmier tel quel et tel qu'il est, c'est-à-dire vraiment un pilier du soin à domicile, et vraiment l'écouter et travailler d'égal à égal avec lui. Et on voit que ça peut rendre les choses difficiles, et le fait de ne pas assez expliquer, ça peut aussi rendre le projet thérapeutique mal compris. Il y a malgré tout des axes d'amélioration qui découlent des problématiques. Être disponible, être à l'écoute, échanger entre professionnels de santé, expliquer aux gens comme aux infirmiers, rassurer et considérer les infirmiers, même si la situation a été difficile, peut-être qu'on a quand même fait le maximum et qu'on ne pouvait pas forcément aller plus loin. Et ça fait du bien de l'entendre aussi. Et enfin, travailler d'égal à égal dans une relation horizontale et qui ne soit pas hiérarchisée.
Il y a un troisième axe qui sort des témoignages des infirmiers, c'est les difficultés qu'a le patient en fait, à se retrouver avec tous les professionnels de santé. En fait, ce qu'on regarde, c'est qu'on essaie de travailler de plus en plus son parcours de soins et on sent bien que pour le soin palliatif, c'est toujours un peu compliqué. Il y a différentes problématiques. Déjà, les Landes, on vous disait, c'est un milieu rural, donc il y a un isolement géographique qui rend difficile la collaboration entre les professionnels. Les infirmiers sont en difficulté quand leur compétence dans l'accompagnement social est dépassée, vers qui on se tourne, c'est toujours très compliqué. Exactement pareil sur l'aspect psychologique, bien sûr, dans le référentiel de compétences des infirmiers, il y a la possibilité de pouvoir apporter une aide dans la relation d'aide, par exemple avec les patients, mais quand leurs compétences sont dépassées, c'est difficile de trouver un professionnel. On a aussi les structures de soins de recours qui, en tout cas dans les Landes, mais c'est représente plutôt bien ce qui se passe en France en ce moment, avec des difficultés en fait d'avoir accès aux structures de soins de recours. Donc on peut regarder cette verbatim où les urgences, c'est pas une structure sur laquelle on compte pour accompagner le patient au mieux. Et puis c'est la mise en musique un peu du travail avec tous les professionnels, avec la coordination qui est très compliquée. Tout le monde n'a pas les mêmes informations. Il n'y a pas forcément de coordination dans le parcours du patient, il n'y a pas d'aiguillage, on ne sait pas qui orienter vers qui. On ne sait pas trop derrière non plus qui c'est qui doit travailler, qui doit gérer un peu tout ça. Il manque vraiment un chef d'orchestre, c'est quelqu'un qui coordonne ce parcours de soins et c'est très compliqué pour les infirmiers et les infirmières de savoir vers qui se tourner et de savoir qui manage ça. Et puis il y a l'hospitalisation à domicile dont on parlait qui peut être aussi un frein. Malgré tout, il y a quand même, on sent que c'est quand même quelque chose qui pourrait permettre d'améliorer l'accompagnement du patient, d'améliorer le patient, d'améliorer sa qualité de vie au domicile. Il y a des structures quand même d'accompagnement qui sont plutôt positives et qui permettent d'accompagner et d'assister les infirmiers. L'équipe mobile de soins palliatifs dont je vous parlais, qui a un regard neutre. L'HAD qui apporte malgré tout un apport aussi technique avec une permanence 24 heures sur 24 par exemple aussi. Et puis les prestataires de santé privés. Et puis, malgré tout, il y a des structures qui permettent un peu d'améliorer cet accompagnement. Voilà, dans le témoignage, la maison de santé pluridisciplinaire qui permet aux professionnels de santé de se rassembler, de pouvoir discuter entre eux, de pouvoir échanger sur les cas compliqués. Et ça, vraiment, cette structure, j'allais dire, locale, permet d'améliorer l'accompagnement des patients. Et puis on a aussi l'approche pluriprofessionnelle qui vraiment permet d'améliorer le quotidien du patient.
On va faire vite parce qu'on va être pressé par le temps. Donc on a discuté de nos résultats, on a vu les difficultés, on va parler rapidement des perspectives. Comment essayer d'améliorer les choses? En gros, trouver du sens dans le soin, on a vu que c'est très important pour les infirmiers, être en accord avec ces valeurs du bien soigné. Je pense que se former pourrait aider à faire cela. Travailler ensemble avec d'autres professionnels de santé, mais aussi avec d'autres infirmiers, ce qu'on appelle des groupes de pairs, c'est-à-dire des groupes où on échange un peu sur les pratiques entre professionnels du même corps, ça pourrait aider sous ça. Intégrer les aidants, l'école de l'aidance, ce sont des choses qui existent aussi en France pour travailler tout ça, et l'accessibilité aux nouvelles thérapeutiques qui peut faciliter les prises en soins. Le médecin doit faire évoluer sa posture, en France en tout cas, considérer l'infirmier comme un pilier du soin, travailler d'égal à égal, et on pense que ce qui est vraiment peut-être le plus important dans la prise en charge de tout ce qu'on a trouvé, c'est faire une réunion un peu de début de prise en charge où tout le monde se réunit autour de la table, le patient, sa famille, les médecins, les infirmiers, tout le monde discute de ce qu'on peut faire, tout ce qu'on veut faire, et là où chacun ne peut pas aller et ne peut pas faire. Et ça paraît important pour comprendre la direction thérapeutique et aussi pour que chacun soit au clair sur ce qui va se passer sur les prochains temps de la prise en charge. Enfin, la téléconsultation pour aider tout ça.
Et donc très rapidement, on sent dans les témoignages que y a cette nécessité de coordination qui infuse et qui sera nécessaire de mettre en place ou au moins d'améliorer. On se rend compte qu'on se pose la question de qui inclure, quel patient solliciter. Il y a plusieurs questionnaires qui existent, d'outils, d'échelle. Nous en France, on a un palier à 10 qui a été créé par la SFAP, la Société française d'accompagnement palliatif. On sent que on a besoin de savoir qui on mobilise, avec quelle aide. Alors il y a des structures qui permettent de le faire sur le territoire landais, en fait, de pouvoir savoir qui utiliser et à quel moment. Et puis surtout, comme on disait, la coordination, qui c'est qui le gère. On a tendance à voir le médecin généraliste comme coordinateur, mais vu l'état du système de santé français aujourd'hui, on se pose la question de savoir s'il n'y aurait pas des infirmières de pratique avancée, ce qui commence à émerger aujourd'hui, qui pourraient être responsables de tout ça. Il y a la communication à améliorer, le décloisonnement de la ville et l'hôpital, parce qu'aujourd'hui il y a une franche fracture entre la ville et l'hôpital, et ça il sera nécessaire de pouvoir le décloisonner avec des HDJ de soins palliatifs par exemple, et la gestion des urgences palliatives. Je repasse très très vite là-dessus, le projet de soins personnalisés, en fait c'est vraiment la conclusion de notre travail. C'est grâce aux infirmiers qui nous ont mis en lumière cette histoire de projet de soins personnalisés qui existe en oncologie en France, mais pas trop en soins palliatifs pour nous. En fait ça sert vraiment à anticiper, savoir ce qu'on identifie chez le patient, quelles problématiques il y a, une inclusion qui est précoce. Un projet de soins qui est personnalisé, qui est évolutif tout au long de la pathologie du patient et de son évolution clinique. Une prise en charge qui est globale avec des thérapies complémentaires, nutritionnelles. Et enfin, on évalue les ressources qu'on a sur place. Je vous épargne cet énorme schéma qui est un peu compliqué, mais si vous voulez le retrouver, en fait, c'est vraiment ce travail-là et ce qu'on peut faire selon en fait, la trajectoire du patient qu'on devrait bientôt mettre en place sur le territoire. Voilà, conclusion, prise en charge complexe, des pistes d'amélioration et un parcours de soins pragmatique. Merci beaucoup et désolé d'avoir dépassé. Sorry for the time.
I don't know if this is on. Oh, it is on. Okay, thank you so much for your presentation. We won't have time for questions, but perhaps if there are questions, you can approach the speakers after the session. So we will invite up our third speaker.
I haven't presented in a very long time, so if I'm a little nervous. My name is Stephanie. I am one of the clinical resource nurses at Connect Place Children's Hospice in Vancouver. So my presentation is on our nurse-led 24-hour line, so help is just a phone call away. I have no conflicts of interest. Just some of our learning objectives, which we will go through later. Coming in, just our competencies, basically communicator, collaborator, leader, health advocate, scholar, and a professional. So in this presentation, we'll go over who it serves, how it works, usage patterns, and the impact on our kids and families. Our 24-hour care line. So Connect Place Children's Hospice opened in November of 1995 at a Glen Bray in Vancouver. We have always had the 24-hour line available to our kids and families, but notice that only really the families that came in for respite would ever call in. Slowly, we have grown, and we now have an Abbotsford Hospice that started as outpatient services in 2014 and has since now has inpatient services. With both hospices, we support pain and symptom management, medical respite, education, art, music and recreational therapy, end-of-life care, as well as grief and bereavement counseling. Slowly, we've expanded to the community-based team in 2018, and this includes hospital care, consultations, and then since then, we've really known that we needed a really good nurse line so that families could call us day or night. And we started doing a bit more education and advertising our 24-hour line. And now any family that comes on the program gets a magnet that they can put on their fridge that they can call us day or night. All right, so we serve all of BC and Yukon. We have about 920 families on the program, and only about 480 actively access our services. The average length a child is on the program is about 6 years. We have 10 inpatient beds amongst our 2 hospices and 8 family suites. So being a caregiver for a child with a progressive illness is stressful. Conditions can change quickly, and families don't always know what to do. So families can access the 24-hour line so they don't feel alone in making decisions. We will take calls every day or night whenever families and caregivers need us. Our clinical staff answer questions and guide their care. At Connect Place, our continuum of care expands beyond the walls of the hospice to meet everyone for services throughout the province. We provide clinical outreach programs through our 24-hour line for families and caregivers. Our 24-hour line is available to families and caregivers 24 hours a day. I feel like I doubled up my notes here. But just so the nurses will answer the 24-hour line, and they will triage as appropriate if they need to talk to one of our advanced practice nurses, whether it's intake, our nurse practitioners, or our doctors. So they can always go triage as appropriately. We have more support during the day, but they can always triage to one of our medical physicians on nights and weekends. Okay, so just here how our nurses are able to triage. So most of the phone calls that come from the 24-hour line can be symptom management, so we help with pain, feeding difficulties, seizures, irritability, and respiratory issues. We have decision-making support to help with child's health. Lots of the times our kids do have advanced care planning, so it's always just kind of confirming with families that do you want to go back and treat reversible causes? Do we want to stay home? Just kind of going back to those conversations we've had previously in admissions or consults in hospital. And then just seeing how urgent is it? Do they need to be seen in hospital? Can they be seen virtually? Can they see their pediatrician the next day? And then sometimes it's just my feed pump's not working, help with the suction machine or whatnot. So we help with lots of different varieties of things and care coordination and support. So we did a dive a little bit into other 24-hour lines. And then one study showed that having the ability to call a line after hours really helped support families in not feeling alone. So they would stay home throughout the night. Only 9% were referred to emergency services. 80% of those callers said they felt really supported. And then there was 6 studies that find palliative care lines are a significant source of psychological support for caregivers. But we couldn't find any documentation on a pediatric palliative care line. So we started tracking calls that came into the hospice in about 2008, but we were unable to distinguish the calls that came through to our 24-hour line and which ones were going to our clinicians. As of June 2020, we've been able to track the calls specifically to the nurse line. So in the past 3.5 years of call logs from nurses, this is a paper tracking chart, so it's not always accurate. We were able to track that we had, I forgot to go through, sorry guys. 1,105 calls from 192 families from June 20 to March 2024. So it's an average about 25 calls per month. Minimum call would be 1 call from families to 1 family that called 57 times, but majority of the families call about 5.7 times. Just so some data here. So we notice that most of the time the families, moms call and then dads. We do only see here that we have about 16% of nurses or other caregivers. I do think this number is a little bit low because we do answer a lot of phone calls from community health nurses as well and home care respite nurses. On our sheet, these are the number of families that have called. Majority of the kids that we see are ones with CNS conditions. So it's about 32% of the patients that we see and about 43% of the calls. So this is just roughly who calls by age group. I thought we would have a lot more calls for the under 1, 5 minutes left? Okay, under 1 age group, because I feel like that's a lot of the calls that come in, but it's really proportionate to all age groups. I'm going to skip a little bit ahead just because we only have 5 minutes left, but just for our nurses to know that majority of the families do call it shift change. So kind of like after 5 to about 9 or 10, when we know lots of the day's resources are no longer in-house. All right, so we did a subsample survey to families that called within a quarter. So from April 2024 to June 2024, so just 3 months. There was 44 families that had called the 24-hour line in that time. We sent out the survey to 40 families. 2 of them were like clinicians that called, and another 2 we didn't have their email address. So we got 13 respondents. 12 found the nurse line very helpful. 1 found it one found it helpful, and nobody said it wasn't helpful at all. So we asked a few questions. The first slide here is, what do you use the 24-hour line for? So a new or worsening symptom, fever, pain, vomiting, decision-making support, do we stay at home, do we go to hospital? Advice around like medical devices, tubes, feed pumps, stuff like that. Support for yourself or a family member. And then 1 family member said other and medication, which we don't normally fill prescriptions for. And then the other slide here, can't even read it, sorry. If the phone line was unavailable, what healthcare service do you imagine you would have accessed instead? So majority of our families would have gone to Emerge. A few would have called 911 or sought urgent care. 5 of them would have tried to see their pediatrician or GP. 1 family said they would have accessed Google if we weren't around. Just some quotes from families. So we're reassuring, professional, helpful. We appreciate the wisdom and experience. Talking through options to help support us is amazing. They'd call back and check in on the situation. They helped us connect to the appropriate professionals at Children's Hospital. It's really caring. It's a key component to the Connect Place program, in our opinion. The reassurance they provided is imaginable. To have these supports and knowledgeable, caring people available is huge. I think this one really pertains a lot to me. It's one of the most important services that Connect Place offers. I think I use this line to know when to bring my child to emergency, to help with decisions, when to go to help with emergency situations. I just thought that was really poignant because I always thought it'd be like the respite is what they would really want, but they say that the 24-hour line is really what they find reassuring. How much time do I have? We're done? I was going to go through some case scenarios, but we don't really have time today. But just highlighting, we have some families that were able to call us for just general symptom management, pain management, and through calling the nurse line in the middle of the night, was able to identify that the childs were actively dying and able to triage out to our community team to just go out and do a home death. So it's not only just providing support over the phone, but they can triage as appropriate as needed. And just another case scenario. So out of this, we did realize that we're not tracking the calls that come in properly. So as of October, we are going to be tracking our 24-hour calls that come in and that get triaged to our APNs or our MDs, NPs, just so that we actually probably not tracking about 40%, I think, of calls that come into the house. And thank you.
Okay, thank you, each of you, for your presentations. I've been so inspired in these nursing sessions. Again, I think these three presentations were wonderful examples of a lot of creativity and advocacy that are going on in our nursing profession, whether it be for patients or families or nurses themselves. So thank you all for your work and for your contributions to the Congress this year. Now I'd like to introduce our next speaker, Philip Larkin. Since August 2018, Philip Larkin has held the Christian Gerhard Jebsen Chair of Palliative Care Nursing within the Palliative and Supportive Care Service of the University Hospital Center. Based in the Palliative and Supportive Care Service, University Hospital Lausanne, he is affiliated to the Faculty of Biology and Medicine, Institute for Higher Education and Research in Healthcare, University of Lausanne. An Irish national, Philip Larkin has over 35 years of experience in the palliative care sector, both clinically and academically. As professor of palliative care at the University College Dublin, he led the development of the All-Ireland Institute for Hospice and Palliative Care, a public health project bringing together the Republic of Ireland and Northern Ireland to improve palliative care outcomes for all citizens. He was president of the European Palliative Care Association from 2015 to 2019. He is currently chair of the International Workgroup on Death, Dying, and Bereavement. His past research has focused on access to palliative care for vulnerable populations, with a particular focus on palliative nursing in relation to informal caregivers and groups often marginalized in accessing palliative care, including patients with mental health issues, disability, children, and palliative care needs in rural isolation. The place of compassion in palliative care practice is also a strong feature of his academic scholarship. He currently leads a palliative care nursing research team at the CHUV and continues to lecture nationally and internationally on nursing care, palliative care, and compassion in care. So I'd like to welcome Philip Larkin.
So, good afternoon. Bonjour à toutes et à tous. Can you hear me? I hope. I will. So, my presentation is about compassion. And I want to say, why is it about compassion? Well, these are just, I have no conflicts of interest, but I am a member of the advisory board of Palliative Vaud. And I hope that you will see I have some learning objectives I'll try to meet. And these are the CanMed competencies I hope to do. So I'm conscious of time, and I have an exercise I'm hoping we're going to be able to do, first of all, before I talk to you about compassion. So why do I think this is important? Well, some years ago I wrote a book on compassion in palliative and end-of-life care. And my presentation today, I interviewed clinicians across the world about what does compassion mean to you? How do you see compassion in practice, and how do we sustain it for the next generation of palliative care practitioners? So my presentation today is based on that. I think for what I want to try to get across to you today, if there was a key message, is that compassion begins with you.
You can't offer compassionate care to other people unless you know how to care for yourself. So if you take nothing away from the next 40 minutes, that's the message you need. To be compassionate to others, you need to start by being compassionate to yourself. And there are many books which can help you. This is one by Christopher Gemel, which is about the mindful path to self-compassion. But there's a lot of evidence, literature, self-help books. It's not difficult to find them. So I suppose the first question is, what do we mean by compassion? And my opening question to you then is, what is the experience of compassion in your life? Have you experienced compassion yourself? Or perhaps in your practice as nurses, and I'm speaking to you as a nurse, have you experienced a lack of compassion towards yourself or others? And I don't just mean patients and families, but I mean within your clinical teams. Have there been times when that sense of compassion has not necessarily been a focus of how the team functions? And remember, as nurses, you are often a constant presence with the patient and family. I was listening to the person talking, Stephanie, talking about the night service. Those times, that's often when the nurse is doing their greatest work in the night hours, because that you are the person closest physically to the patient. So I want to do a little exercise with you. This is called photolangage. You're probably familiar. And basically what I'm going to do is I'm going to show you a series of photos. And I just want you to choose one. And the important thing is, don't think about it. I just want you to see an image, and if you feel that image does something to you, note it in your head. And then maybe we'll just have a couple of minutes where you can share with your colleague your reflections. And of course, to do a photolangage, you have to have a question. And that is the question I'm going to give you. So focus for a moment on the question. What does compassion mean to me as a palliative care nurse? If you just sit back and relax, and I'm just going to take you through some photos. Okay, so just think for a moment. Was one of those images, did it say something to me about what compassion means to me as a palliative care nurse? And maybe just for a second, if you can, have a conversation with the person next to you, just to say, what was it about that image that affected you or made you think? If it didn't, that's okay. I'll explain why in a minute. But I'll just give you a couple of minutes to do that. And maybe then you can tell me. You're all a bit hard to see when you're stood in the middle. I can see you better from here. That's better. Okay. Okay. I'm not giving you long for that piece. Any comments, any thoughts from the audience? Anything in particular that struck you? Any image? Anyone like to share? Yes, please.
The image that struck chord with me was the images of, there's actually two of them with cracks.
Okay. Okay.
Just the fact that compassion can be about seeing the cracks, but not necessarily having to fix them.
Yeah. Yeah. Thank you. Absolutely. And of course, for nurses, we're trained to fix. You know, when I was a student nurse a long time ago, sitting by a bed and talking to a patient was absolutely, because there are things to clean and there are things to sort and there is a sluice room to clean, and it does not involve parking your backside by a patient in the bed. So that was the doing was really important. Nurses are often judged by their doing. Okay, thank you. Any other thoughts or comments? Yes, please. Okay, yeah. Okay. I think that's also a very important message about how we deal with brokenness within ourselves or within our team members, because we can often manage it very well with our patients. We have the training for that. But when the brokenness is within the team for some reason, that's a very different story, you know. And the self-compassion, that goes back to how do I see the compassion with others. Okay, maybe one more, and just one more comment or anything. No worries if not. So let me tell you why I show you those pictures very quickly. So I'm going to talk to you a little bit about the work of Henri Nouwen. So Henri Nouwen is a theologian, and he wrote this little book about compassion, which I'll mention in a moment. And he said that compassion is not a feeling or an emotion. It's not in your head, it's in your guts. And the word he used was a Greek word, splankizomai, and you need to feel compassion. You have to have a wow moment or an aha moment for a compassionate response. And that's why by showing the pictures, it has to hit you. And sometimes when you know compassion is needed, it's because you had this physical sense of, wow, something has to change, something has to give here. There may be an issue. So thank you for your feedback. So going back to this, I suppose at the end of the day, compassion is a wisdom tradition. All the great faiths of the world talk about compassion. In the Christian faith, it's often the Good Samaritan that's given as an example. But all the world understands that compassion in some way is an important element of who we are as people, as citizens, as people who live together. Often the challenge, and this is often in the literature, is, well, what's the difference between compassion and empathy? And we often get this a little bit confused. So I'm just going to give you a simple way of understanding it from my point of view, or what I think it is. Basically, compassion is the other side of the door. Empathy is the key that unlocks the door to compassion. So you need to have empathy. That's a really important element. But empathy itself is not enough. Empathy will undo the key and undo the door, and that allows you to step over the threshold into compassion. And to do that, you have to do action. So compassion is really judged about the action that you do, not what you feel. We all have to feel, but the compassionate response is based on action. And the work of Marie Vachon and Darcy Harris have really understood this in the context of what's the differences between empathy and compassion. There are many, many definitions, but I want to give you this one. I mentioned Henri Nouwen, and he wrote this little book. It comes from a Christian perspective, but it doesn't have to. You can look at many different documents, and incidentally, a lot of what's written in palliative care about compassion comes from a Buddhist perspective. For example, the work of Roshi Joan Halifax, who has done some amazing work about compassionate care. But I like this definition in some ways, because it says compassion asks us to go where it hurts, to enter to places of pain, to share in brokenness and fear and confusion and anguish, which you do every day with your patients. Compassion signifies the total immersion in being human. That's an awful lot that I ask of you every day when you go into your job. And when I did my interviews with people, they'd say, someday I just need to be a good doctor or a good nurse. That's a step too far every day. I can't do that unless I have the support. So there are many definitions, but you need to be conscious what being compassionate asks of you as a person, because you are the person that make the difference. I'll come back to that at the end. Compassion is always a response to suffering. So the next key message is there has to be suffering in order for you to act in a compassionate way. And in our world today, in our geopolitical situation, we see compassion, the need for compassion, in many different ways. Just as an example, compassion can be different depending on your exposure. So I can see the terrible things that happen, for example, in Lebanon and in Israel, in Palestine. But I actually supervise students in Lebanon, in Beirut, in the University of Saint Joseph. And when I talk to them on the phone about what is it like for you today, I have a different compassionate response than if I'm just seeing it on the television. So compassion can be mediated by your proximity to the level of suffering. The other thing is that compassion is cultural. So I work in Switzerland. I'm not from there. I'm Irish. And I think it's important to reflect for you, particularly those from different countries, but let's say here in Canada, what is the expression of compassion in your culture? I don't know because I'm not from your culture, but it's an important reflection point. My culture is a very interesting one. You have little pretty pictures here of the lake at the back of my house in Galway in the west of Ireland, and the mystical ideals of Ireland as a beautiful country, which is very nice. But when I was a child, I grew up in a time of difficulties, of stress because of religion, of fighting, of difficulties on the north and the south, which is one of the reasons we developed the All Ireland Institute. That experience shaped who I am. And the cultural experience and my experience of compassion is because of who I am and what I grew up in. But that will also shape your experiences of compassion. So we need to acknowledge what is the culture and ask some questions about many of the things we heard this morning around access or inaccess to care, or people who are marginalized or who can't access services. What does that say about our system? Because actually, if you understand it within your culture, it may help you to become a more compassionate caregiver and do the best you can, because that's all that we can ask of you. And I know this is a really hard picture, but given our current situation, I think it's an important one. And for me, it's a really important message, because it's not just about the suffering, it's about palliative care. Because this is an image from some time ago, a little boy from Syria who died on a beach trying to find a new life. But what do you see? You see the soldier who witnesses the suffering. So that's the second thing. For compassion to happen, you must witness the suffering, but then you must act. And he picks the little boy and he moves into a place of comfort. Every day, as nurses, but as all clinicians, you do that act. You witness the suffering, you do something, and you pick that person, you cloak them, you cover them, and you move them to a place